Dan Syazmi, mem punya A very good morning to everyone again. Thank you for joining us back today for the webinar. I am Major Dr. Sanggari Anak Perempuan Murugesu. Again, will be serving as your moderator today. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the chat box in the YouTube channel. We have our team to collect all your interesting questions, and I'll bring them up during the question and answer session. You can also WhatsApp the question directly to my personal number. Kindly write your name at the end of your text. Please don't forget to scan the MMA QRs code to get your 12 CPD points. The QR code will be given tomorrow starting from the break session until the end of this webinar. If you have any problem with the QR code, kindly contact Colonel Dr. Shazli. And there will be a feedback form will be given at the end of this webinar. Please kindly fill the feedback form to get your e-certificate. Without further ado, we will call upon Colonel Dr. Shazli. This topic. Colonel Dr. Shazli to present her basic second and third trimester ultrasound topic. Please kindly welcome, ma'am. Thank you.
Thank you, Sanggari, for the brief introduction. I'm already on live, right? Okay, fantastic. Thank you guys for still being with us for today. I know it's a long talk since yesterday, hence why we've kept it for about half a day. Before I start, just a bit of correction for Sanggari just now, because I'm the one who was in charge of this talk. So the QR code for the MMA as well as the feedback form so that you guys can actually get your e-certificate will be shared from today onwards. So stay tuned in between the breaks and especially after the webinar, it'll be played on so that you can have your chance to get your CPD MMA points, which is 12 points, as well as your link to your to the e-certification. So don't miss that chance. Now let's go on to my talk today. This is a very simple talk. I'll be talking on basic second and third trimester. Many of us would have done this and would have started doing this. So it would not be non-familiar for many of you. All right. So generally today we shall only be talking on basic key component for the doctors, especially those who cares for pregnant women, to actually do their second and third trimester scan. And I shall not be discussing on anomaly scans. Okay, today's not on an anomaly scan. I'll walk you through the skills that you need to do a good ultrasound for the second and third trimester. Okay, so briefly, let me tell you the discussion topic for today. So we'll just go on to basic physics and knobology. I'm not sure if you heard about knobology, but if you do ultrasounds, one of the topics that often will be discussed is on knobology. Knobology basically tells you about the knobs on your ultrasound machines, okay? I'll walk you through on the second and the third trimester, sorry, there's a typo there. Second and the third trimester anatomy and second and the third trimester dating scan. If it applies, I'll walk you through how to do an amniotic fluid measurement, and I'll also walk you through some key basic concept on assessing the placenta localization. All right, so introduction. So basic physics, knobology, and tomography. I won't go on the details. You can actually go on to read on yourself. There's a lot of slides and also a lot of YouTube talks on the net right now that you can actually engage and get yourself acquainted with this topic. So basically, what is an ultrasound? It's basically just ultrasound waves that travels through the body and bounces and reflect differently, and it gives you a different, feedback feature or image based on the difference of tissues. Okay, so this is basically a sonar. Okay, and it reflects. The reflected waves are actually called echo. So if it's a fluid, then it will pass directly onto the tissue or the I would say an item. Okay, but bone is hard, so it does not reflect water. Water reflect waves very well, hence why we also use the bladder as a window to do our scans. All right, and also and the last one but not least in the human body is soft tissue. So soft tissue is neither bone nor fluid, so it's somewhere in between. So you will see the feature somewhere in between a feature of a fluid as well as a bone. All right, so amniotic fluid is black for the fetus. Amniotic fluid is black. The skull, the bones are white because it reflects back all of the sound. Okay, amniotic fluid is black because the wave passes through the structure. All right, and the placenta and the fetal bone are basically gray depending on how dense the tissue are, because some waves are passed through and some waves are reflected. Please tell me if I'm too fast, Rangari. It's okay to drop me in between. I'm good with two-way interaction. So acogenicity of the anatomy of a fetal tissue, you can see here. Let me put on my pointer. Is this my pointer? I put my pointer. Yep, laser pointer. So the bone, you will see bone as white, and as you move along to the fluid, it will be anechoic. So how we describe it is anechoic, hypoechoic. Some soft tissue are isoechoic or hyperechoic, where you see bone or air because it does not reflect waves. So that is hyperechoic. And at the end of the spectrum is anechoic because it reflects all of the waves, so we call it anechoic structure. Okay, so what is nabology? I'm not sure if this is a new term, but this is a term that you need to know, or you have an idea of if you have been doing your scans. Now, I simply saja ambil ini ya. Okay, this is basically the feature of your knobs. Okay, the knobs on your ultrasound. You should have all these. The one which I've actually highlighted are the one that you really need to know. Okay, so you will have your one is your overall gain. Okay, and then you would have your TGC, which is your time gain composition. Your overall gain would be here. That's the one when you adjust the features of the anatomy of the fetal to be, is it too white or too dark and whatnot. Now TGC is how deep you adjust the structure and how you assist that wave pass through the structure. And this is the depth knob. Okay, how deep you want to go into the structure, how well you want to, how superficial you want to approach the structure. And in the zoom, basically tells it's a zoom. So you want to enlarge it or you want to make it smaller, depending on what is your, what you need to do with the structure. And focus, of course, your focal point is where you concentrate most of the wave is. And it's important to actually focus and adjust the focal point where tissues are concerned. All right. So this is basically an image of an overall gain. Now look at this far right. What do you think about this far right image? This is too much, okay? Sorry, this is too low, okay? Too low. And what about this? This is too much, it's too white. You can't really appreciate the fluid versus the bone, also the soft tissue. Now what about this? This is just nice. It's a proper adjustment of an overall gain. Now this is the image that many of us should actually aim for. All right. Now this is what I meant by the time gain composition. You know that knob on your side where there's a lot of, if I go back to here, so I know some of you will just adjust this. Either you put it to, some would like to in the middle. I prefer mine a bit in the middle unless I'm doing deeper structures, okay? But I've seen some of the doctors adjusting too far, to either extreme, far left or far right. So this is what it's used for. So if you adjusted your gain, so it should be equal throughout the whole depth of your image. If you adjusted this, you need to make it a bit more in the medium gain. This one is not enough. Okay, so adjust it to just enough and just nice. Okay, it's just about being able to capture a good image so that we can actually appreciate the structures that we're looking at and being able to identify that well, and hence able to take a good measurement. Okay, now what about depth? Now depth is for this. This is too small. Okay, you want to measure the AC here. I'm sure you guys have identified the structure. This is probably an AC, but it's too far. When you do it too far, then you'll be missing some landmarks that is important for you to get a good image. All right. Now, what about this one? It's too deep. It's too much. Okay. You won't be able to see the structure nicely. You need something that's just nice. What about this? Assuming that you want to see a feature profile here, this is just nice. You'll be able to see the forehead, some nasal bone, maybe a portion of the mouth. You can even see the thorax. So you want to get a depth where you are able to appreciate and enlarge the features nicely. Okay. Now, what is this? What is this, you think? Maybe the fetus? This is actually a portion of the umbilical cord. Okay, so this is too far. This is zoomed. So make sure if you're identifying very small structures, zoom in, enlarge the image and get it, and then only do your measurement. What about focus? Now, this is what I meant by focus. When we have adjusted our depth and our zoom, you want to bring your focus to somewhere in the middle here, where I've put the arrow, because you essentially want to see this, you want to observe the structures over here, okay? So that you'll be able to take a nicer. What about this? The focus is to down, this is to up. Look at when you try and appreciate this. If you adjust the focus in the wrong position, this become a bit more brighter than it should. You're concentrating all of the sonar around this area. And on the other side, you're concentrating the sonar at this area. Now, is that the way? No, we want to focus on this area in the middle portion here. So you'll be able to get a very nice, well-defined image. Okay. Now going on to tomography, I just put in a slide on this tomography because it matters in sense of orientation. So 3 important planes when you do ultrasound. You have your sagittal plane, then your coronal plane, and then your transverse plane. Now, transverse plane is something that a lot of us are very familiar with. It's when you cut your body to up and down. It crosses, crosses our body. Now, what about sagittal? Sagittal basically parts the body to left and right, and coronal parts the body to front and back. Okay. Now, this is important to being able to appreciate as you cut through the fetal structures. All right. Now, other thing which is very important is to orientate your transducers, your probe here. Now, each probe will have an indicator. Now, the new ones will have an indicator. Make sure that before we start on, you must confirm that your transducers are at the correct position. Now, if you hold your transducer, all right, make sure that if you're doing a transverse cut, the indicator marker will always point to the patient's right. And if you're doing a sagittal cut, let's go here, a sagittal cut cuts through the body, differentiate to left and right, okay? So make sure that the transducers indicate the marker oriented points towards the patient's head. So transverse, if you're doing a transverse, make sure imaging this is my transducer head. that if you're doing a transverse, make sure that this head is on your patient's left. Then all of your image, when you see on the screen, all of the image on your patient's right will be your left. On your patient's right, left will be your right. So that's, don't mix that up. And if you're doing a sagittal cut, make sure the marker here will be towards the patient's head. Okay, so if you notice, if you're putting your probe this way, then how you move your probe will be anti-clockwise. Okay, it will be anti-clockwise, not clockwise. So movement should be anti-clockwise. All right. So imagine that when you scan a baby on the mother's abdomen, uterus, now imagine that this fetus is in a breech position. Now, if you're doing a sagittal cut, this is the image that you see in your screen. And if you're doing a transverse cut, this is the image that you should see. All right, the stomach on, you will be seeing on your left, but it will be the maternal right. Okay, terbalik, jangan salah. What about this? Sama juga dengan ini. If doing a sagittal cut, okay, mom's going up. If you do this, this is if you are doing a sagittal cut for this woman, if you see this image, automatically you will know that this is the mother's head, this is the mother's feet, this is the anterior of the abdomen, this is a posterior abdomen, and this fetus would be on a Catholic presentation. All right, and if you see this image, automatically you would know this is a longitudinal line. All right, so this is a transverse cut. This is a smaller gestation. Then you would see maternal's left, maternal's right. Okay, maternal's right will be your left. Maternal's left will be your right. Anterior, posterior will be the same. All right. Now, before we start any ultrasound, after you've palpated the abdomen so that you have a vague idea of where the baby is, always do a robust scan. There's many terms for this. You can call it a robust scan. You can call it a fast scan. You can say a four-quadrant assessment. It doesn't matter what term you use for this. What matters is the intent. The intent is to roughly gauge where the fetus is and sweep through to have an idea of some structures, which is important. You get automatically, when you do a robust scan, you immediately know the fetal presentation, the fetal lie, the amount of liqua, overall liqua on a global scale. And the other thing, you'd be able to appreciate just roughly where the placenta is. So a robust scan, if you want to use this technique, it's fine. You sweep in the middle, left and right, 3 scans. So you'll be sweeping this fetus this way. And then you do another transverse robust scan, 1, 2, 3. Then you'll be appreciating this fetus this way. Okay. Now, so a short reminder, check the transducer's position before you begin to scan. It's critical to understand how the image is oriented in the screen so that you don't get confused. Okay. You can quickly do, please do a quick robust scan or a quick scan to see all of the quadrant of the maternal's abdomen, to see number and position of fetuses to avoid error when you're scanning for more detailed. Okay, and then you'll be able to tell a fetal position by doing a single transverse ultrasound. Okay. So moving along, the second and the third trimester anatomy. So anatomy is important. Before we go on to how to scan it, you need to know what structures are you doing. Are you going to be able to see when you cut through different slides of the fetal body? So we need to learn to identify the normal fetal anatomy of the head, the heart, the abdomen, the spine, and maybe a bit of the extremities. Okay, so in the fetal head, you have the skull, face, the brain. Now, important structures within the brain would be the ventricles, the CSP, scapum septum pellucidum, the thalami, the cerebellum, and the base of the skull. Now, these structures here, especially the brain here, I want you guys to really concentrate, because these are the landmarks that you that you need to identify to ensure that you're taking a good scan, and a scan which will not give you a very large discrepancy when measuring the fetal biometry. Okay. Now the skull, again, skull is bone. Bone is hyperechoic. When you have a hyperechoic structure, it would be white. All right. So, so you see the skull, okay? So most important to identify the skull. This is from a smaller gestation. This is from a larger gestation. Now, what about this profile picture here? You'll be able to see the skull. You see some skull at the forehead there, and I'm sure you can appreciate this nasal bone there as well, and maybe a bit of the ribs, a bit of the spine as well. Okay. So the face. This is what the face look like in a profile. When we say a profile, it would be a sagittal cut through the middle. And if you do a profile very early, the second trimester, you'll be able to see this very nicely. Now, what are the features of the head and the body that you can identify clearly? Now, I've helped you out. I've put down all this arrow. You can see the forehead. This is the nasal bone. This would be the mouth. When you see the mouth, sometimes you can appreciate the jaw and the mandible. What about here? Look at this structure here. This is the fetal spine, and you can see a nice abdomen here as well. All right. Well, that probably that's not. That definitely is not the a bony structure. But if you go above, you see this white area here. Those are the ribs. Now, here is what the face looked like in an old profile feature of a fetus. Sagittal. Now, usually when you get this, you can get this image with you scanning around 32 weeks, because that's at the point where the life buoy is most in many pregnancies. You can see this feature very nicely. Now, going on to the brain. We are going to look at the brain starting from the basic diagram. Now, I've put this image here, slice A, slice B, and slice C. The gray structure where you're seeing at the center of the brain is our normal fluid structures, which are called the ventricle. And the three lines are at a different level of the brain as you slice through the brain when you're doing an ultrasound scan. And we need to know how the brain looked like at each of the slices in order to get to the correct level to determine the gestational age or the size of the fetus. Okay. Now, if you're going at the level A, this is a transverse cut at the level A, you'll be able to see this image. Okay. So you see this in the long arrow. This would be the ventricles. Let me help you out here. Okay. This would be the ventricles, and here, and you see this semi-aquate structures. This would be the choroid plexus. Now, if you're scanning and you're cutting through this slice, you know you are at a higher level, which is level A. Okay. Now, if you're at the middle brain, level B, you'll be able to see this structure. So, what is in this structure? So, this structure is the you see these three lines here. I'll enlarge it in a while, so don't worry. This structure is called the cavum septum pellucidum, and this structure here is called this long arrow here is called the thalamus. Sometimes the thalamus, many have described it to be in a heart shape. So let's go and let me enlarge this for you. So this is the thalamus, okay, and this is the this is the cavum septum pellucidum. You see 1, 2, and 3 lined, and you see a somewhat like a heart shape there. That's the thalamus. Okay. So the other structure, which is important to identify at the midbrain, would be this line here. What is this line? This is called the falx. Okay. It's a strong white line. Okay. And if you're at level B, you'll see it stopped here. It doesn't go to the end. All right. If you go to the end, you are way up above. You're at level A. Okay. Remember that. Okay. So again, the thalamus is like a heart shape, and the cavum septum pellucidum appears like a white line, and the strong line that passes through in the middle is called the falx cerebri. Now, this is a very important landmark and level because this is where we would do our BPD and the head circumference. I'll walk you through that in a while, okay? But let's go to the next level. Now, if you cut lower to level C, this is a lower brain. If you see this arrow here, if you see this image, now you are cutting the brain to the cerebellum level, okay? And you would see a very fat H shape here. Here, I've drawn this for you. It's like a fat H shape, and this is the cerebellum. Okay, we don't use this. We use this for a detail scan. Okay, I would use it for my detail scan. But you guys, I just need to know this level because sometimes you would have gotten this image and this is how you're cutting. So that's why when I talk to my houseman and my MO, oh, this baby is a bit flex, lah. This baby is a bit extending the head, because we are looking through the image, and as the baby moves, you can see the image and you get to imagine how the fetal's head is moving. All right. Now, if you go and do a scan and you see the structure, two white, the skull, and then these two white structures here, which is the bone actually, yeah. So if you've gone there, you've already sliced through the bottom at the base of the skull, and that two hyperechoic structures is actually the skull, the bone at the back of the skull base. So this is too low, not the place where we would do our BPD and the head circumference. Now moving on to the heart. Remember, I'll just walk you through the normal anatomy first. All right. Now, heart, the second and third trimester, you can see clearly beating. Yes, it has four spaces: the right and left atrium, the right and left ventricle, and blood flows through the chambers to supply to the body. This is a cross section of the heart, of the chest, and by doing so, you'll be able to appreciate the heart. Now remember, the heart chambers contains blood, so blood is fluid. Fluid is anechoic, all right? And the walls of the chambers are echogenic because it is a soft tissue. This is a larger gestation. This is a smaller gestation, all right? Moving on to the ribs. Now, these views of the chest show small hyperechoic or echogenic structures. These are the bones that you see. So these hyperechoic white structures here, these are actually the ribs. What about this? You see this echogenicity is somewhat in the middle, right? It's a bit more darker. So this is where the heart is. This is another darker structures. This is where look at this. This is an area of the abdomen. So this would be the stomach, okay? And over here would be the fetus abdomen. All right. So you've seen perhaps of that, a nice image of the abdomen. So in the abdomen, you would have the stomach, the umbilical vein, the umbilical cord, the kidney, the bladder, and the spine. Now, if you're doing an AC, you would need to be able to identify this structure because it matters in the sense of finding a nice landmark for you to get a proper measurement. Okay, so stomach and umbilical vein. This is a transverse section through the abdomen. You can see here, and the abdomen and the stomach, like I mentioned, contains fluid, so it's black, and the stomach normally varies in size depending on what is the content of the stomach at that moment, okay? And beside the stomach, you will see the umbilical vein. Now, umbilical vein, it carries oxygen from the placenta to the fetus, and because it also contains blood, it is also anechoic. The level of the stomach and the umbilical is very important because we measure at this level to determine the gestation, okay? So the umbilical cord, now this is a very nice umbilical cord. You see a nice thorax, nice abdomen. You can see the umbilical cord from the fetus and going on to the placenta. So the image on the left shows the cord inserting into the abdomen, and the image on the right shows umbilical cord at a cross section, okay? You would have this is another very, famous term. It's called the Mickey Mouse sign. The Mickey Mouse sign, 2 ears and 1 face, okay, 2 arteries and 1 vein, okay, that's the umbilical cord. Now, if you see this structure, please turn it to a cross section so that you would get this image to ensure that you're seeing 2 arteries and 1 vein, okay. Now, this is the kidney. In a sagittal cut, the kidney would be an oval shape, and if you do a cross section, the best image would be if you can get the fetus to be spine up, then you would see two rounded structures on either side of the spine. Okay, this is a very nice image of the kidneys. Okay, so if you notice, if you're cutting through this, you don't see the stomach, and you can neither see the umbilical vein. You should not see that pun kalau nak buat abdominal circumference. Okay. Now this is a bladder. This is a sagittal cut. Okay. Now the bladder would sit nearer to the femurs. This is a coronal. This is a coronal view, and this is a transverse view. Okay. So bladder is water, it's urine, so it's also anechoic. It's black. All right. So sometimes if you are just learning, you will confuse the stomach and the bladder. But pay attention, the bladder would be nearer to the femur, the stomach would be nearer to their ribs and just below the heart. Okay, all right. So again, bladder, femur, bladder, umbilical cord. All right. So bladder is low near the leg. The stomach is high near the umbilical cord. Now the spine. This is a sagittal view of the spine with the fetal head to the left. Okay. Now, if I say the fetal head is to the left, and this is a sagittal view always points to the maternal. Your marker to probe marker to will point to the mother's head, kan? So, what position is this fetus in? All right, yeah, this is a bridge position. All right, okay, easy kan? You letak satu plane je. Oh, I know this position already. Okay. So these are the transverse view of the spine. If you have the spine up, spine up will be the best if you want to see the spine on a transverse cut. Okay, this is this belong to a younger fetus because it's not that well developed. This belong to an older fetus because it's more developed. You can see the structures a bit more clearly. Now these structures on the side of the spine, which is a bit, which is also white, are the ribs. Okay, arms and hands, okay, are bones and they are hyperechoic. They are white, okay, and you can actually clearly see that, especially if you're scanning a younger gestation. Okay, I'm showing, the younger gestation just to encourage you to do more scans and be able to appreciate the beauty of all these scans. It's interesting to do scans, so nampak cantik sebenarnya. So something that I look forward to when I do scans, actually, you'll be able to appreciate fetal structure very well. All right. So this is the lower leg and the foot. So this is the tibia, the fibula, and this is the kaki. Automatically, I know this is we would know if we do, this is a sagittal cut. Okay. So the femur is above the hip. Okay. If you see two bones, that's not the femur. Femur is only one bone. Okay. So when we're doing a scan, make sure that it is the femur that you're looking at and not the tibia or the fibula. All right. So key points here in identifying normal anatomy structure is that you should be familiar with the normal appearance first of this structure. And you need to understand that in order to accurately date the fetus or do a proper scan, you need to be able to identify the structures correctly. Okay. So this is a moment where I know many of you are waiting for. I'll go through and how to do the measurements correctly. Okay. So in this session, this section of this talk today, we will learn how to measure the head, the abdomen, and the femur to find the fetal gestational age, okay, at the point of the scan, and to identify at the correct level of the structure, and to choose the best ultrasound image to assess the fetal age. Okay. So accurate data is helpful in determining, in managing normal pregnancy. And it is very essential in ensuring that we're getting a good date so that we can make sure that timing of delivery is correct. And then in the first trimester, not the topic that we'll be talking here, we usually use the CRL, more so the CRL. The SAC, if you don't see the CR yet, but if you see the CRL, if there's a fetal echo there, tolonglah jangan ambil SAC untuk buat dating scan. I jadi irritated sikit sebab salah Compared to fetal SAC, sorry, IUGS versus the CRL, CRL is more accurate, okay? And in the second and the third trimester, we would use a combination of the BPD, the head circumference, the AC, and the femur length. Now, of course, of which trimester the best to do a dating scan? The dating scan would be best done in the first trimester, not the topic that we'll be talking today, okay? I'll concentrate more on the second and the third trimester. And for fetal dating, never, please do not use suboptimal image. Please ensure that the image is optimally done, okay? So, for the second trimester, for the second and third biometry, make sure, please, if you can, do at least two measurements, okay? And after you measure, the ultrasound will calculate the gestational age, and sometimes they give you an estimated due date lah. You can also use a chart. So if you're doing a diameter, the width of the head through the middle, this is how you do it, okay? And if you're doing a circumference, this is how you do it, okay? So the black dotted line here is how you would actually twerk your calipers and your measurement, all right? So for BPD, we would take the middle portion of the brain at the level of B, okay, level B. So make sure that it is at the level B where the thalamus and the CSP are, and then make sure that the skull looks smooth and oval and the brain structures are equal on both sides, okay? And when you measure BPD, it is outer to inner, ataupun some people do inner to outer, whichever the preference. The most important is it's outer to inner or inner to outer, okay? And the line between the cursor should be perpendicular to the fox. What does that mean? It's like this, okay? So this is a transverse cut of the head, okay? This is where the level B is. You can see the falx. This is the cavum, septum, pellucidum. It's three line here, and you can see the thalami very nicely, the heart shape, okay? So this is the plane, okay? So when we do, okay, when we do a scan of the BPD, sometimes we need to appreciate that as the gestation grow kan, image sometimes can differ. Ataupun baby tu gerak kepala sengit sikit, you can nampak image macam ni. Sometimes you tak nampak CSP sangat-sangat. Okay, sometimes it's clear, sometimes nampak macam box, sometimes it's not. So just know that you are still within the normal variation because of the movement and because of the gestation. Now, the other thing that you will find if you scan a later gestation macam 38 minggu punya week, that the skull would be very hard already kan. So you will be able to appreciate that it's not easy to see the inner structures here, especially if the fetus is already engaged, okay. Now, those are the challenges that you'll be able to address as you get more competent with your scan, okay. Now, good placement for BPD is this. Find a falx, okay, and outer to inner and perpendicular to the falx, okay. So identify the falx, perpendicular to the falx, all right. Now, don't forget this, identify the falx, perpendicular to the falx, and you are at the level B where you can see the thalamus, the cavum, septum, pellucidum, and the falx in all these three structures nicely. And remember what I say about the falx. The falx is separuh je. Oh, the usually orang akan ajar, this is the arrow sign. This is what they call as the arrow sign as well, right? Okay. What do you think about this placement of the calipers? It's strong, kan? Ini sengit. Okay, it's not perpendicular to the falx, so don't do this. Make sure that you are perpendicular to the falx. Okay, this is ideal placement. Okay, this fetus is only 15 weeks. You can see the thalamus, you can just see the CSP, tapi you nampak kan dia macam hazy sikit. So sometimes this picture is some people find it's a bit small. Enlarge, make sure that you enlarge your image so you can appreciate your structures better. Okay, and notice that the BPD measurement is put, the calipers are placed perpendicular. So this is nice. Okay. Sometimes you can see the head tipping like this. So you can have images like this. Just ensure that you are at the right plane and you are measuring correctly. So this one is at 25 weeks. Okay. So again, you can see all the structure. The placement of the caliper is perpendicular. Okay, this is a good placement as well. Now, moving on, yeah. So another way to judge your image is to know where the ventricles are. Remember the normal anatomy? The ventricles are at the higher portion of the brain. Okay, if you're saying this, okay, and you want to do a DVD, okay, ataupun a HC later on, okay, this is a too high placement. You don't see the forks, you see the forks going straight sampai ke hujung. You don't see the thalami, you neither see the cavum septum pellucidum, but what you do see is the choroid plexus and the ventricles. This is too high a place, a cut, okay, a slice. This is also too high, okay. The box is continuous, you see the choroid plexus, you see the ventricle. This is too high, not at the right landmark. Okay. Now, what if you've seen here? This is cutting through C. You see the fat 8. You're not at the level of the where the BPD should be. This is a cerebella. Okay, not mid-dental. Correct placement of BPD. You would see this. Okay. So again, this level is where you would actually do your head circumference as well. All right. Okay, circumference, same thing. Make sure you are at the same level. How you do the head circumference would be the outer margin. All right. So again, this is correct placement, outer margin. This is correct placement, outer margin. But please appreciate, this is 16 weeks. This is 32 weeks. Okay, so this is how images would look different to you. Okay. What do you think? What do you think about all this placement here? Are they nice images? How would you choose your image? So this is too small. Okay, this is too small. This is just nice actually. What about this? Okay, image is not too bad. It's well zoomed. Okay, tapi look at these two. Okay, this is too low. This is nearer to the base of the skull. Okay. Now, abdominal circumference, this is the image where we want to see. Now, this baby is in a Catholic position with the fetal spine on the maternal left. Okay, so senang nampak. So spine, usually when you do an abdominal circumference, ensure that your spine is either on the left or the right, and you see the stomach, and you see the vein here. You do not see the heart. You do not see the kidneys. You do not see any other structure minus these three structures here. Okay. So abdominal circumference, measured at the level of the umbilical vein. You please make sure that you can see you can see your stomach, you can see your spine, and you can see your umbilical vein, and you do not see kidney and bladder macam I cakap. Okay. Now position of the ellipse is at the outer ring here. Okay. So fluid, black. Okay. And then the spine would be here. This would be white. Okay, and sometimes you can see a bit of the rib. All right, so good measurement. Okay, good zoomed image as well. Okay, now what do you think about this? Is this a zoom? Is this a nice AC? It's not. Okay, why? Because you can see a lot of the ribs. Okay, banyak sangat ni. So I know this person has cut through slanted. Dia tak cut so if this is the baby's body, dia tak cut macam ni, dia cut sangat macam tu. Okay, the abdomen is not round. Okay, so look, you should get a nice round image, and then you can see the umbilical vein, and then you can see the heart here. So they're cutting slanted to the fetus body. Okay, this is not the level AC. Now what about this? This is too small. All right. So you need to make sure that the AC fills out most of the screen so that you'll be able to do a nice measurement. Now, what about this? Do you think this is the correct image, correct level for this AC? What is this? It's the kidney. So a bit too low, go up higher. Okay. Now, femur length. Okay. Rotate the transducer until the femur is as long as possible. Okay. You want to take as long as possible. You want to take the measurement, the greatest length of the bone. Now, if you see two bones next to each other, okay, that's not the femur, that's the tibia fibula. All right. Now, remember that bone is white. If you see structure macam ni, a bit hazy, it's not white. These are the cartilages. So this is not where you should end. It should be from blunt end to blunt end. They are most prominent white. So this is a nice. This B ni is a nice measurement, not A. Okay, not A. Here, this is the cartilage. Don't take that. All right. So this is the image of a 16-weeker. Sometimes I think this is a bit too small, the image. Besarkan image ni. Now this is at 32 weeks. So measure some. It's easiest. It's best to measure the femur nearest to the transducer. You can see one femur, two femur here. Choose this femur, whichever femur nearest to the transducer. Okay. Now let's look at this. What's wrong with these images? It's too small. Okay, this is too small. Is this the femur? No, it's not. This is the tibia and the fibula. All right. So for measurement of the fetal anatomy, make sure that you are at the correct plane, at the correct level. Your calipers are placed correctly. And if you can't see the head, abdomen, or femur anatomy very well, don't take those measurements for the thing. Make sure that your image are optimum before measuring. Okay. So I'll try and make this fast. I just got the amniotic fluid and the placenta left. So moderator, sorry, I ambil masa sikit, minta maaf. So moving on, this is the amniotic fluid. Okay. So kita akan learn how to measure the volume. And we will learn two keywords, which is oligohydramnion and polyhydramnion. Oligo is decrease of the AFI, amniotic fluid, and the polyhydramnion is increase and in the amount of the amniotic fluid. Now, all of us know many of us know this amniotic fluid function. It's to cushion the baby. It allows fetal to grow. It allows the fetal structures, especially structures macam the heart, the lung to grow. It prevents infection. It keeps the temperature constant. And so it is important that the amniotic fluid be a normal level, not too much and not too low, because it is a sign of another abnormalities lah. I will not go there. I basically akan hajar how to get proper measurements sahaja for today. Okay. So amniotic fluid produced by the mother first in the early pregnancy and later taken up by the fetal kidneys and the lungs on the later gestation. So two ways in measuring the amniotic fluid. You can either do the maximum vertical pocket, and the other one is the amniotic fluid index. I know many of you are familiar with the amniotic fluid index, but how and when do we use either of this cara, the MVP or the AFI? So the MVP are used in a singleton pregnancy less than 24 weeks. If you're measuring MVP, a singleton pregnancy less than 24 weeks, and we measure MVP for all twins or multiple pregnancy. We do not use amniotic fluid index, okay? So the normal value for MVP is 4 to 8 centimeters. All right, and we must ensure that this is the deepest fluid pocket, devoid of any fetal parts or umbilical cord. Make sure that it is a free plane, okay, nothing of the fetus there. So kita ambil 4 quadrant, okay, 4 areas, and you want to take a perpendicular, the deepest. So for amniotic fluid index, we divide it into 4 quadrant, and then kita ambil within that 4 quadrant, the deepest pocket, free of umbilical cord and fetal parts. And the normal measurement for the AFI is 5 to 24. Saya ulang, for MVP, we do for all singleton pregnancy before the age of 24 weeks, and for all twins, and the normal measurement is 4 to 8. For amniotic fluid index for AFI, we do for all significant pregnancy beyond the age of 24 weeks gestation. And we divide it into 4 quadrants, 4 pockets. And the normal measurement is 5 to 24 centimeter. So divided into 4 quadrants, okay, measure the vertical height of the deepest pool of each quadrant and add on all. Okay, so this is how you do it. When you do the vertical pool, when you are I notice when you do your probe too, the probe is not to the feet to the mother tau. I've seen probe mark. You don't slant it to the mother. You want to put the pocket, cari paling that quadrant tu paling banyak air and you place the probe perpendicular to the katil, to the bed. So make sure the mother is lying flat as much as you can. All right. Okay, so oligohydramnion, if you're doing an MVP, it will be less than 4 centimeter. Okay, if you're doing an AFI, it will be less than 5 centimeter. Tapi be mindful for AFI. This is the one that we usually do. Please refer to us if you start seeing less than 7. Please refer to us. Jangan tunggu sampai less than 5. Less than 7, please refer to us early. Alright. So kalau kata polyhydramnion, okay, for MVP it would be 8 centimeter and above, and for AFI it would be more than 24 centimeter. All right. Amniotic is high. Sorry, maaf. Now look at this image. Okay, you know automatically ini nampak macam poly kan? Okay. So if you take a measurement, make sure jangan ambil dekat macam ni, jangan cross like this. Okay, if I can draw kat ni. If I can draw. So jangan when you put a caliper, jangan letak macam ni. Don't do like this. Okay, you want to go away. You want to choose kat sini. Okay, here. Okay, so this is away from the fetal punya structure tu. Okay, you adjust lah sekarang. Okay, alright. So abnormal fluid is important. Amniotic fluid is important function of in protecting the fetus, and abnormal amounts can signal an abnormal pregnancy. And oligohydramnion and polyhydramnion can be determined by the ultrasound. So once you have a poly or oligo, please refer to the specialist lah, to us. Okay. So simple session on placenta localization. Important skill when you want to do a placenta localization is to identify the placenta position. Lepas tu, you want to evaluate for placenta previa, and then just roughly on a brochure, how do you assess on that? I won't talk too much on that. Okay, so most important is position and making sure that what you're seeing is not previa. So placenta previa is a complication in which the placenta covers all or part of the opening of the cervix, and placenta abruptio is a separation of the placenta from the uterus. The function of the placenta, as many of us would know already, is for the transfer of oxygen and nutrient from the mother to the fetus, and transfer of the fetal waste product to the maternal circulation, and can be seen on the ultrasound as early as 10 weeks POG. Okay, so this is a posterior placenta, this is an anterior placenta. So if these are the lateral type. Okay, this is the right lateral, this is the left lateral placenta. Okay, so this image here is a sagittal image of a fundal placenta. The moment I say this is a sagittal image, you know that the probe marker too is pointed to the maternal face, kan? So you see this, okay? So this is a fundal placenta, all right? Position of a placenta is very important. Normal position is over 2 centimeters from the os. And if the placenta covers the cervix, the risk of bleeding on the second trimester is big. If you have APH, and certainly during delivery, risk of bleeding is high. Hence, patient would need to be done under cesarean section at the hospital. So how do you assess the placenta localization, the location of the placenta? First is to identify the internal os. This is the external os. Ni external os. This one is the internal os. Identify the lower edge of the placenta, and this would be the lower edge of the placenta. Okay, and then you measure between the distance between the placenta edge and the internal os. Where? Here to here. Okay, all right. Okay, measure the placenta from edge to the internal os. So here 1 to 2. This is 3.25. So usually this is actually up lah, sebenarnya. So low-lying placenta is a placenta less than 2 centimeters from the cervix but does not cover the os. If you have a marginal, it partially covers the os. If you have a complete previa, this is a type 4. This covers completely the os. The marginal are the type 3, and the low-lying will be the type 2, the type 2 and the type 1 lah. Okay. So look at this. The distance. This is the internal os. I'll just besarkan ni. Okay. So this is the internal os. This is the edge. And then this person here has measured it 1.25. So this is a low-lying placenta. Ataupun this one would be this would be the type 2 lah. Okay. This is the marginal type 2. This is the placenta edge. This is the cervical os. It's very near. So this is 2 to 3. Yeah. And then this is the internal os. This is the placenta. This is the type 4 or the complete previa. If the placenta is in normal position on the first ultrasound, so previa will not develop later in pregnancy. Now, if it's a low-lying placenta, a marginal placenta, a complete previa in the second trimester, low-lying placenta or marginal placenta can sometimes be the one yang type 2 or the type 2, type 1. Sometimes by the time delivery, it can grow upwards lah. Okay. Tapi the one, the type 3, type 4, the complete previas usually don't grow. Okay. Don't move upwards. So the caution is, if you have a bladder, some people use with bladder or not bladder. My point is that if you have a bladder, please know that sometimes they can distort sikit your image because of the contractility of the uterine wall. So just adjust ya, tengok macam mana. So this one nampak macam placenta previa tapi with a full bladder. Once you have relieved the bladder, then it's actually not previa. Sometimes you have uterine contraction. The funny is uterine contraction. You wait, make sure you wait. Once the uterine contraction resolve, okay, this is not previa. Okay. Now placenta abruptio happens. Sometimes happen, and it's a separation of the placenta from the uterus. And usually, if it occurs in the third trimester, sometimes jarang-jarang boleh juga berlaku in the second trimester. So abruption causes abdominal pain, uterine tenderness, and vaginal bleeding, and sometimes, if it's not addressed promptly, maternal and fetal death. So very important. So this is at a small gestation. You look at this, nampak macam ada brush. This is a small one. If you see this, like a hematoma macam ni, please refer. Okay. So usually on ultrasound appearance, usually the edge of the placenta, but maybe in the placenta. Okay. So abruptio can be hyperechoic, isoechoic, or hypoechoic, depending on the state of the blood or the blood clot where you're seeing it. Abruption is still possible even if you don't see it, because the moment you see an abruptio in larger gestation, usually at least 500 cc is already ongoing. So if you suspect abruptio, please refer urgently to the hospital. Okay, Sangga, I'm so sorry. I think ada lari masa sikit. So any question? Ada question ke?
Thank you so much, ma'am, for this informative talk, and also thank you so much for correcting my mistake just now. Yes, it was supposed to be given today, and I accidentally told tomorrow. Please accept my apologies. And I hope our medical officer would get a very good exposure regarding second and third trimester obstetric ultrasound through this topic. Ma'am, I have a few questions here.
Ada soalan ke? Okay, I thought
Ada,
tak ada soalan sebab simple je ni.
Ada, ma'am.
Okay.
But it's actually a bit out of general ultrasound question. The first one is from Major Dr. Suhairi. What is the difference between 2D, 3D and 5D ultrasound? He just want to know what's the difference.
Okay. The dimension. So 2D, dia macam ni. In an ni physics sebenarnya. In an axis when you're doing ni, you have your X, Y, Z, whatever dimension that you involved in. A 2D basically look at two dimension, your X and Y plane. Ini bit of physics. The moment you put 3D, the next dimension you letak adalah time. Tapi this time is not real time. 4D is real time. 5D tu, I tak sure lah. I tak ingat dah 5D tu apa. Tapi basically, the difference are the dimension. And then if you look at the dimension, it will allow you to generate the image. These are all the ultrasound physics. So the more dimension you generate on an image, you ultimately lah macam ni lah. Any human being kalau you nampak baby dalam perut tu macam what it is as it is, that's the ultimate goal in ultrasound. So mana tahu later on we can actually construct a hologram of how the baby is, macam cerita sci-fi dan komputer tu. So those are actually the dimension that you're looking at. Tapi most important for any MOs, you must master your 2D ultrasound. Okay, must master, because you will not understand your 3, your 4, your 5D kalau you tak master your 2D, because it's a most basic plane, most basic dimension that you need to appreciate fetal anatomy in that sense.
Okay, ma'am. The second question is, ma'am, can you share some important points for twin pregnancy, ultrasound in twin pregnancy, ma'am? This one is from Dr. Muhammad Zarul.
A note to all MOs, the most important point for twin pregnancy is to diagnose it early before 12 weeks. When you see 12 weeks, and please, if you see a twin pregnancy, the first thing is to make sure that you can appreciate your lambda and your T sign to define the coronicity. Okay, and janganlah bagi surat and then tulis lambat. Okay, kalau you rasa you dah dapat, you tak sure coronicity tu, please refer early and call us or call your colleague, call us to get an early appointment if you're not sure, because beyond just 12 minggu, sometimes kita dah tak boleh nak tengok sangat the lambda and the T sign tu. So it will change our management. So with twin, tak payah sibuk the second and third trimester. It will be the first trimester yang paling penting. Identify early. Please identify the chronicity early and refer to us early so that we would be able to take the necessary procedures to confirm that pregnancy punya chronicity as well. Itu je for twin. Yang lain tak payah, jangan miss ada some of us yang miss twin. Missing twin is a big for me, because we've had a few cases where the midwife, the nurses, the doctors, semua fundal height ni dikata kira sama je. When it came to us, it's very obvious it was larger than Date. Bila cari ada second twin dekat sebelah yang seorang lagi tu. So that one is also a big no juga, please. Okay.
Ma'am, is it okay for one last question? It's
sempat ke? Kacau Tamira punya masa pula.
Primary care level.
Nanti dia jealous, I masa banyak. Sorry.
Tak
izin Amira, sorry
In primary care level, what gestational recommended to do second RME, ma'am? The ultrasound for second RME. I think this will be the last question, ma'am.
Your second RME. In primary care level, okay. Usually you guys do your first RME masa berapa minggu?
Usually is booking, ma'am. Booking will be our first RME.
Okay, then booking, I'm going to assume all of you aim booking at 12 minggu kan?
Yes, ma'am. Usually.
Okay. Aim 12 minggu is important, because Beyond 12 minggu, dating would be difficult and assessment of twin would be difficult juga kalau kata you jumpa twin lah. Okay. If you're doing 12 week, then the next RME, I think you should aim around 22, 24 or 20 weeks. Kita begitu, because that's also the rough time that you'll be able to start seeing the anomalies if you can see, and be able to identify paling the abnormal fetuses, macam the adult, the patal, because you will start seeing macam very small babies, very oligo. Okay, kalau tak boleh, paling lambat pun the second RME, you please aim before 28. Okay, before 28. So usually first trimester, so how we are planning is first trimester, second trimester, third trimester. Macam tu. So 12 weeks, 24 weeks, 32 weeks. All right.
Okay, ma'am. I think if any of the audience
PM lah siapa nak tahu.
Yes.
Or just chat box lagi, I go to the YouTube and jawab soalan mana yang boleh. Kata telefon je, kan? Senang. Okay.
So please feel free to message Dr. Shazni privately, and thank you so much, Ma'am Shazni.
Thank you, Dr. Sanggari. All right.
Okay, we will just take 1 minute intermission while preparing for our second speaker, that is Lieutenant Colonel Dr. Amirawati. Just wait 1 minute. Without wasting our time, I would like to welcome Lieutenant Colonel Dr. Nur Amirawati binti Aminuddin to give her next presentation on updates on cervical cancer screening. Please welcome Dr. Amira. Thank you, ma'am.
Assalamualaikum, very good morning. Thank you, Sanggari, for the introduction. We move along into our second topic of the day, which is update on cervical screening. So cervical screening in Malaysia has been opportunistic since introduction in 1969 by cytologic-based program. What do I mean by opportunistic? Though in those days, patients will come with other sorts of complaint, not because of cervical screening. They will come because of PV bleeding, they will come because of contraception counseling, and they will come because of any vaginal discharge. Then when they see doctors, they will ask to do cervical screening. Not because they come to the doctors because of the cervical screening itself. So rapid understanding in our human papillomavirus, which is the precursor of cervical cancer or any cancer lesion, and also the role of HPV, and as well as clinical application of primary prevention and secondary prevention, undergoing significant changes throughout the years. I will further explain regarding to that. The cervical cancer is actually a leading cause of mortality among women. It's the third most common cancer in Malaysia. In 2020 alone, an estimated about 600,000 women were diagnosed with cervical cancer worldwide. And more than half of that women died from this disease. And it is most commonly diagnosed in 23 countries, and the leading case of cancer in 36 countries, and vast majority in countries like our country itself, Southeast Asia, Sub-Saharan Africa, Melanesia, and South America. So the target WHO have provide a good guideline, which is the target of global strategy by the 2030, whereby we want to vaccinate 90% of all eligible girls against HPV and screen about 70% of eligible women at least twice in their lifetime, and effectively treat 90% of those who positive screening test or any cervical lesion, including palliative care when needed. So we go to Malaysian statistic. This is all statistic 2012 and to 2016. We go to the female, we not talk about the male cancer disease. For the female cancer disease, like I said before, the cervical cancer are the third common cancer, with age standardized incidence rate is about 6.2. It is after breast cancer and colorectal cancer. And it's more commonly in the Chinese population, which is the ASR is 6.8, followed by Indian population and Malay population. So in Malaysia's cervical cancer profile, the latest one, because 2016 it was 6.2, but the latest in 2022, the ASR already going up to 10.2. Why is going up? Because of better screening problem. We can detect the cervical cancer early. So actually the statistics become higher. And from the 2019 alone, 1,000 women are died because of cervical cancer. So taking about cervical cancer, Malaysia has coming out of prevention strategies. It consists of primary prevention, secondary prevention, and also treatment as well as surveillance. What is primary prevention? Primary prevention is actually vaccinate all the girls at the age of 13 to 15 years old. This is already has been offered to our female teenagers since 2010, and the primary cohort target is actually 13 years old. By 2022, we already vaccinated 8 in 10 women already received final dose of vaccination. Remember, HPV vaccination prevent HPV infection, which is can lead to any precancerous or cervical cancer later. So secondary prevention for Malaysian strategies is actually to screen all the women at the age more than 30 to 65 years old. We try to detect early and treat any precancerous lesion, any cervical lesion, precancerous and cervical cervix, cervical cancer. However, in 2019, only 4 in 10 women has been screened for cervical cancer in last 5 years. Not even half of our women population has been screened for cervical cancer. Remember, cervical cancer is preventable, so early detection is much more important. Other than that, Malaysia has provided good supportive care, good treatment, and mentioned already our government already built in Institute IKN, Institute Cancer Negara, to treat and provide a maximum and comprehensive treatment for any cancer, including the cervical cancer. So we also answered the WHO strategies regarding the elimination of cervical cancer in 2013, whereby 90% of girls fully vaccinated, 70% were screened at 35 years old and 45 years old, and 90% women who identify cervical disease get appropriate treatment. We're talking about cervical cancer. Cervical cancer have multiple risk factors. The most common is sexual promiscuity, priority more than 5 and above compared to low priority, early marriage, any family history, and smoking. How to detect any precancerous lesion or cervical cancer is first by doing physical examination and history taking, pelvic examination, pap smear, and HPV testing. So when you see any woman in clinic come with some sort of complaint to primary healthcare, to Resat, always ask them if they come for contraception, always have them when the last pap smear, because if they did not done the last pap smear more than 3 to 5 years ago, they must repeat the pap smear examination. So the treatment for cervical cancer, of course, the definitive treatment will be surgical treatment, chemotherapy, and radiotherapy. And how to prevent? How to prevent cervical cancer? First, the primary prevention, again, HPV vaccination, avoid sexual promiscuity, and use condom during sexual intercourse. Usually, patient will come with some sort of sign and symptom for cervical. Is not clear-cut symptom for cervical cancer. Patient may come with abnormal discharge, unable to control the bladder, abnormal vaginal bleeding, dyspareunia, sudden weight loss, unable to urinate properly, and leg pain. So what do you know about cervical cancer? Cervical cancer screening. When we talk about cervical cancer screening, we must know anatomical of reproductive system. So this is the recap. I think most of us already what is the anatomy of reproductive system. The big triangle here is the uterus, and this is the vagina. Connecting between these two is the cervix. Okay, this is our fallopian tube. And we have two sides bilaterally, right and left, and also the ovaries. So what is the cervix actually? Cervix is a cylinder-shaped neck of tissue that connect between vagina and uterus, posteriorly vagina and inferiorly vagina and superiorly uterus. It's located at the lowermost portion of the uterus and primarily is fibromuscular tissue. So when we feel it's actually hardened, firm inconsistency. It has two main parts actually. It has ectocervix and endocervix. Okay, the ectocervix is lined by stratified squamous epithelium, and the endocervix lined by columnar mucinous epithelium. It has two cell lining. When we do speculum, we can able to properly visualize the cervix. That cervix that you can visualize during the speculum examination is actually only part of the cervix that we call ectocervix. That is the ectocervix. And at the center of the ectocervix, you see a passage, what we call external os, that connects between the vagina and the uterus. So the endocervix actually line at the tunnel of the cervix. Yeah, until I show the picture. And the overlapping between these two, ectocervix and endocervix, there is a region ataupun area that we call transformation zone. This is the diagrammatic picture of the cervix. This is the normal uterus diagram. This is what we can see from the speculum examination. I hope you can, when you do speculum, you're able to appreciate where is the cervix, where is the os, okay? When you do the speculum examination, when you see this, this is properly visualization of the cervix. This is ectocervix, and the passage inside at the center is actually external os. Where the endocervix is actually here. Yeah. At around the tunnel between the vagina and the uterus. So this is the histological anatomy. whereby this is the fibromuscular tissue, the pinkish lining ni. Okay, this is the ectocervix that lined by stratified squamous epithelium. And this is the maroon color is actually the endocervix lined by columnar mucinous epithelium. So overlapping these two cells is actually as transformation zone. Why the transformation zone is actually the most important? Because it is most susceptible into the metaplastic carcinogenic changes. Is in direct influence by estrogen and also HPV vaccination. So any precancerous lesion or cervical cancer will occur fivefold in the transformation zone. We go how to approach, screen and treat the cervical cancer or any precancerous lesion. WHO has come out a very good guideline for screening and treatment for pre-cervical cancer lesion and cancer prevention. It had two main approach, which is screen and treat approach, whereby the decision to treat is based on positive primary screen test only. What does it mean? It means when you do any cervical screening, tak kira lah whether it is cytology, conventional pap smear or liquid-based pap smear or HPV pap smear, you treat the patient straight away. Yeah? The second one is by screen, triage and treat approach. You screen first, after you have a positive primary screening test, you do the subsequently triage by another testing, usually followed by colposcopy, and then you treat the patient. Okay, this is depends the feasibility, the acceptability, and the resources at that center or in that population. In remote area or in low cost country, we cannot do skin triage entry approach. The cost will become higher. In this case, the screen and treat approach is more suitable compared to the screen, triage and treat approach. Okay, we move along into the cervical screening test itself. Traditional method that you all know is pap smear. Actually, pap smear is a perpendicular test. It's a cytology testing. When the cytology results are positive, diagnosis is confirmed by colposcopy and appropriate treatment is informed by biopsy of suspicious lesion for histological diagnosis. So effective pap smear actually have reduced fivefold the incidence of any precancerous lesion and cervical cancer over the past 50 years. How you do pap smear? It requires a wooden spatula that we call air spatula. Patient will need to lie down in the couch with knee bends and wide open. The speculum should be inserted into the patient vagina, and you must properly visualize the cervix, the ectocervix and the os. So after properly visualized, then the air spatula should be inserted and rotated about 360. So the sample collected. And after the sample collected, it should be smeared into the glass slide. After smear into the glass slide, it should be fixed by ethanol 95%. After that, we can send to the pathology lab for imaging under microscope. Okay, that is conventional pap smear. After 2014, in Malaysia, we already moved towards liquid-based cytology. It's almost the method is almost similar to conventional pap smear, but instead of using wooden spatula with a glass slide, we use the plastic brush, plastic kit. Okay, it's a new method of preparing cervical sample for pap smear. Is aimed to improve diagnostic accuracy and reduce the number of false negative tests due to its optimal viewing of cellular features due to reduction of air drying artifact and obscuring background elements, and therefore reduce the number of unsatisfactory pap smear. Okay, we go, what is the advantages of liquid-based pap smear? Yeah, the wooden spatula, the conventional type, why it is not so popular anymore? Because the advantages, first, it is complete or nearly so complete to capture all the cellular material sample from the patient. In conventional pap smear, only 35% of sample have been captured. But compared to LBC, liquid-based pap smear is almost complete. More than 90% sample is captured. And sample randomization is better and improved preservation of the cellular sample, because after we collect the sample by brush, we immerse in the fixation solution. So all the sample have been fixated into the fixation solution. And this is improved the individual cell visualization, it's decreased obscuring factor by the blood, by the mucus, and by any debris, because by using liquid-based cytology, you can even do the cervical screening during menstruation period. Compared to the previous conventional pap smear, you can't do during menstrual cycle. And consistent cell viewing, consistent cell location and viewing size area. So, like I said, the method is almost the same. You need to do speculum after properly visualize the cervix, and then you have to rotate 360 degrees to obtain the appropriate sample. So, we go, what is the difference between conventional pap smear and thin prep pap test? Thin prep pap test ni lah yang liquid based cytology yang kita pakai brush tu. When we see is only fraction of collected sample, only 35% je collected, rather than liquid based cytology almost all, more than 90%. And sample smear factor often produce poor quality. Kalau you tengok here at the slide, there is so messy cell overlapping each other, and there is no individualization of the cell. Compared to the liquid-based cytology, cell is become individualized, easy to see, and all the debris and all the white blood cell and red blood cell has been removed. There is no more obscuring factor. So the slide may fail to accurately represent sample and not reflect patient actual condition. And cell on the slide may overlap with obscuring blood, mucus and other material, and making the visualization of cell is very difficult. So compared to the liquid-based pap smear, liquid-based cytology, cell on slide are more clear, nampak lagi cantik, clear of obscuring element and distributed evenly for ease of visualization and produce multiple representative and reproductive sample. Imagine kalau our pathologists have to see a lot of slide like this one, kan? Nampak macam serabut je, so lagi penat nak tengok, compared to this one is more clearer and more easy to detect any abnormal cell. So other comparison between liquid-based cytology and pap smear, the cellularity is always better and cleaner background and uniform distribution in liquid-based cytology. Cellular overlapping mostly seen in the conventional pap smear, and architectural changes happen, nampak sel tu dah tak elok tu, happen in conventional pap smear. And inflammatory cells in more seen in the conventional pap smear compared to liquid-based cytology. This is other cell slide sample of conventional pap smear compared to the liquid-based cytology. This is much clearer, the cell individualized, which is and not overlapping. Okay, we continue with HPV DNA testing. The first testing that I talked about before this is a cytology test. This is the DNA test, which is HPV, human papilloma virus DNA test. It attests to identify a group of high-risk carcinogenic HPV genotypes. Okay, high risk. HPV, they either have multiple genotypes, either high-risk genotypes and his low-risk genotypes. Usually HPV DNA testing, we concentrate into the high-risk genotypes, which is 16, 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, 59, and 66 and 68. But the higher risk genotype that cause precancerous lesion and cervical cancer is actually 16 to 18. It causes 70% to 70 to 80% caused by 16 to 18. That's why when the first HPV vaccination developed, they targeted the HPV 16 and 18 first, which is bivalent yang kita tahu, and Cervarix. The bivalent type that we offer our teenager at 13 years old nowadays. The HPV DNA testing can be done every 5 years as solely testing or combined with pap smear. For women over 30 years, at the interval at least 3 to 5 years if the patient have negative both testing. Okay, it's a use polymerase chain reaction with amplification technique to detect presence of HPV in sample. Dia guna testing PCR and amplification techniques. So, why the HPV important? When patient have HPV infection, most of the women can clear up the infection within 2 years. Okay, only 5% that will become persistent and progress into the precancerous and cervical cancer. However, the progression takes about 10 to 15 years to progress to cancer. So it's a very slow process. So in 10 to 15 years, any woman should have at least twice or thrice cervical screening. So if any abnormal or any positive findings, we can treat rather than patient have cervical cancer better. So early detection and treatment of any abnormal cells can prevent cervical cancer. What about patient already been infected with HPV? Can vaccination clear the infection? Okay, HPV vaccination may reduce the chance of abnormality developing in cervix, but it cannot clear the existing infection. So therefore, patient have any HPV infection, make sure they have regular cervical screening at least 6 monthly until the HPV infection become negative. So what is the role of HPV vaccination here? HPV vaccination, they have 3 types. Bivalent consists of two HPV genotypes. Quadrivalent have 4 genotypes, which is 16, 18, 31, 33. And now we have nanovalent. They have 9. They have 9 genotypes. Okay. In patient or in women that have non-sexually active or virgin, when they have the HPV vaccination, the coverage of HPV infection is up until 90%, which is very, very high to protect them against HPV infection. However, in patient with non-sexually naive, had any sexual intercourse before, the coverage is only 60 to 70%. But in patients who have infected with HPV before, they still benefited with HPV vaccination, but the coverage only 20 to 30%. Remember, when you give the HPV vaccination, you give 4 valent or 9 valent. So when the woman actually infected, for example, infected by the 16 genotypes, they still can cover by other genotypes that not be infected, like HPV 18, 31 or 33. So they still benefited. If you been infected with HPV before, you still benefited with HPV vaccination, but the coverage is not higher, is not high as the sexually naive. Okay. So we move along to direct visualization with acetic acid. We also can screen the cervical, any cervical lesion by visualization by acetic acid. But this is required very experienced examiner. Direct visual assessment of the cervical of the cervix using 3 to 5% of acetic acid solution to visibly whiten the cervical lesion. So when we do speculum, we see the cervix and we put the acetic acid solution. It must between 3 to 5%, not less than that, not higher than that. Okay, it is temporarily produce what we know as acetowhite lesion. When there is any cervical lesion, the area that has abnormality will increase the whitened area. So it will appear after 1 minute and may last up to 3 to 5 minutes in the case of CIN1, CIN2 or 3, or as well as invasive cancer. But it's only appropriate if the transformation zone is visible, typically in younger patient less than 50 years old. Kalau postmenopausal, usually the visual inspection with acetic acid is not suitable, and it difficult to establish and maintain quality assurance. Therefore, the sensitivity and specificity of VI testing is quite variable because, like I say, sometimes you use the different concentration of the alcohol, sometimes the examiner eyes, because it depends on the examiner eyes. Okay, so this sensitivity and specificity is quite variable. So what we can see from the VIA lah, direct visualization of by using acetic acid. This is normal cervix. It's a pinkish. This is the external os. This is what we can see from the speculum examination. So when we apply the 3 to 5% acetic acid, we can see there is a aceto-white changes around the external os. I hope you can see. This is the abnormal area whereby the suspicious lesion that we suspected. And this one also, not much as this the above picture that we can see, ada sikit kat sini. When we see this, so we suspected this is where the lesion occurred, then we can do the biopsy by using the punch biopsy. Okay. Usually the VIA direct visualization, we not do it alone. We always accompany with colposcopy, or we doing during colposcopy. What colposcopy is a way of looking the cervix through the magnifying glass, magnifying device called colposcope. It shine the light into the vagina and onto the cervix and enlarge the normal view. Kalau kita buat speculum, nampak cervix tu besar ni, but by doing colposcopy, kita enlarge the cervix and then we see on the monitor, in the monitor. Okay, the exam allows to find problems and cannot seen by our naked eye. Kalau kecil, masa speculum tu we cannot see. Kalau kita use the aceto-white acid to see the abnormal changes pun very difficult. So we use during the colposcopy untuk enlarge the image. And then when the result of cervical cancer screening test show abnormal changes in the cervix of the cervix. So when we do colposcopy, normally patient dah ada first screening test, such as abnormal pap smear ataupun they have positive DNA testing. So this is type of patient were subjected for colposcopy. So this is how you do colposcopy, almost the same. Patient have to baring and then knee bend and wide open, and then we insert the speculum. After insertion the speculum, we can use light from the colposcope to shine and capture the image. Alright, they capture the image. In the colposcope, we also during the colposcopy procedure, we can also do the aceto-white acid aceto-white acid direct visualization by acetic acid, and also we can do a Lugol's iodine test, whereby the applying low-dose iodine at the cervix, at the lesion area, there is low uptake ataupun pale. Color nampak pale saja, tak nampak kuning macam normal tissue biasa. And also during colposcope, kita boleh guna green light. Apa tu green light? Yang di mana, which is why you use green light. When we shine the green light, we can see better visualization of the blood vessels at the cervix. Kalau nampak increase blood vessel ataupun multiple new vascularization, that area also kita consider an abnormal area which is required the further assessment by biopsy. Okay, we can see nampak sikit dekat sini there is aceto-white acid changes. Yang ni is not so angry looking. This is CIN1. CIN2 tu nampak lagi banyak and more reddish area. Okay, kalau CIN3 tu dah nampak lagi lagi banyak vessels, lagi besar dia punya aceto-white changes. Okay, we move along into the ROSE project. ROSE project ni actually is a new project in Malaysia. Is founded by Prof. Wu in UM and collaborate with non-profit organization, whereby is a self-testing. It tests a DNA instead of pap smear and it require mobile technology empowered. Okay, what actually is the ROSE project? ROSE project is removal obstacle of cervical screening. Sekarang when we ask patient why they don't want to do the cervical screening. Usually there is many barrier, is fear, takut, sakit, and then embarrassment, inconvenience, susah nak datang banyak kali ataupun they cannot go to the certain health center that provide the cervical screening. Lack of awareness, patient tak tahu, you have to repeat, ingatkan sekali je dah buat. Poor infrastructure in patient in remote areas, very difficult. They want to come just because of cervical screening and lack of dedicated resources and staff. So the ROSE project remove all the obstacle by using what? By using self-sample. Sometimes if you apply for the sample, they can send sample to you and then you can courier the sample back to them. Is designated for Malaysian women with local needs and challenges in mind. Is evidence-based tool and approach to cervical cancer screening. Is driven by empathy for women screening experience and embodies safety, privacy and dignity through sample. Maksudnya before this, if you want to do pap smear or if you want to do liquid-based cytology or any other testing, you must ada doctor and patient. Doctor will do it for you. Ataupun the health worker will do it for you, not you doing by yourself. In ROSE project, they empower you to do the cervical screening by yourself. So you pergi toilet, you collect the sample sendiri and then you seal sendiri and you bagi dekat the health worker. So tak malu dekat situ and then is tak sakit. Alright. So how you take your own HPV testing? You must prepare undress from the waist down. Remove your underwear, remove the swab from its plastic tube, avoid touching and contaminated the tube. Dia macam cotton tip, dekat atas tu ataupun macam yang kita ambil culture culture swab CNS tu. So when you holding the swab, you hold at the not hold at the tip, you hold at the body. So get into comfortable position by lifting one leg up. After you nak buat baring pun boleh, kalau you buat kat rumah ataupun you nak buat dekat toilet, you boleh buat berdiri, okay? With your other hand, gently spread and wipe, buka your skin of your vagina, insert the swab until the red line and then twist it for 10 times rotation. Sometimes it can be very little pain and discomfort. And after you collect your own sample, you masuk balik in the cylinder tube and then you put in the ziplock bag and then bagi dekat staff ataupun healthcare provider. So it's simple. And the result, you will get the result by SMS. If you have any abnormal result, the doctor will contact you straight away for further testing. or if the normal result, if you have normal result, the only HPV testing that you can do is after 5 years. Okay. So summary recommendation for the general population, like I said, WHO suggests either the following strategies: by HPV DNA detection by screen and treat approach starting 30 years old, and regular screening every 5 to 10 years. Kalau you guna HPV DNA, dia every 5 years. Kalau you guna conventional pap smear ataupun liquid based cytology without any HPV DNA testing is 3 yearly. So HPV DNA detection, screen, triage and treat approach pun sama. Start from age of 30 and regular screen at the every 5 to 10 yearly. So take home message for today. By the time WHO now, by the time 2030, we eliminate all the cervical cancer because it's preventable. It is the third most common among Malaysian women and can be prevented by first HPV vaccination as a primary prevention and regular screening by secondary prevention. I think that's all. Thank you. Any question?
Thank you, Ma'am Amira, for this topic. Ma'am, I have 2 questions here, ma'am. The first one, ma'am, is there any role for HPV vaccination in male, ma'am?
Okay. Yes, there is a role HPV vaccination in male. Bear in mind, HPV infection can also occur in male as well as in female as well as in male. The male can be a carrier of HPV infection. You may not have the symptom, but you can be a carrier. So if it is good if the male also can be vaccinated. But now HPV vaccination still considered quite early in our Malaysian society. So we try to vaccinate all the girls first, then baru kita vaccinate boys. Tapi kalau you rasa your husband ataupun you yourself as a male want to get HPV vaccination, there is no wrong. It also can protect you from the genital warts and everything. Okay?
Okay, ma'am. Ma'am, this is the second question and final one. If patient do self-testing, that's under the ROSE program, and it comes back positive, usually the patient will come and see our doctors in primary care center. Do those doctors need to repeat the cytology, or they just can refer for colposcopy under ONG?
No. No need. They can straight do for colposcopy. Sebab one of the criteria for colposcopy is abnormal HPV DNA. Bila you buat cytology and then is it depends. Either you buat conventional pap smear ataupun liquid based pap smear. Sometimes like I said before, the conventional pap smear is not reflect the normal cervical condition kan. So it best you terus refer untuk buat colposcopy. Tak payah nak susahkan patient untuk buat pap smear lagi, nanti nak tunggu lagi. Sebab result kalau you all buat dekat result per it's not gonna come back so soon kan. 2-3 bulan. So nanti patient pun worried 2-3 bulan. So you terus refer. Nanti kalau you refer to the any specialist center, you just cakap the HPV DNA testing positive, refer for further assessment for colposcopy.
Okay, ma'am, associated with the previous question, which is more accurate, the HPV, the DNA, or is the cytology, ma'am? Which is more accurate?
When you talk about accuracy, we cannot talk about which one is more accurate. Again, it depends the availability. Of course, the HPV DNA testing is much more much more feasible and acceptable macam the Rose project, but bear in mind it carries much higher cost. Not every center have HPV DNA testing. So in the center that doesn't have any HPV DNA testing, you still have to go to conventional pap smear and liquid birth cytology.
Okay, ma'am. Thank you so much for all these wonderful answers, ma'am. And I think the next session, ma'am, will be with ma'am again. But we will take 1 minute intermission break, ma'am.
Okay.
Okay, we'll right back. Thank you, ma'am.
Saya nak pergi toilet sekejap.
Boleh.
Macam mana saya nak letak dia dekat atas? Saya tak menang.
We will move on with our next topic. That is uterovaginal prolapse with Lieutenant Colonel Dr. Nur Amirawati again. Welcome, ma'am. Thank you, ma'am.
Thank you, Sanggari. So we move along into our third topic of today, which is uterovaginal prolapse. Yeah? Ataupun sekarang we already changed the term is pelvic organ prolapse. Uterovaginal prolapse is defined as protrusion of uterus and vagina beyond anatomical confine. The term of uterovaginal prolapse has been updated into to the pelvic organ prolapse, and incident between 2% in nulliparous and 12 to 30% in multiparous. The prevalence of uterovaginal prolapse is about 10%. And among that 10% to 37% is grade 3 or grade 4. And most of them have parity more than 4 and above. And 25% patient is between 36 to 40. So patient yang before menopause also can also have pelvic organ prolapse. And more than 70% of patient with pelvic organ prolapse never consulted a doctor. So we must know again female reproductive anatomy. Later we talk about support, system of support between female reproductive anatomy. This is the fallopian tube, ovaries, uterus, and the cervix. Bear in mind, sorry, this is a very busy slide. This is the bladder, is located anterior to the uterus, and this is rectum as well as the sigmoid located at the posterior of the uterus. This is the uterus in the middle, and this is the vagina plane. So we go about support of the uterus. Support of the uterus, it has primary support and secondary support. The primary support is considered muscular support, which is active support from our muscle, which is pelvic diaphragm, perineal body, and urogenital diaphragm. Urogenital diaphragm ni dia ada from levator ani muscle and also coccygeus muscle. The functional support yang hold the uterus is called mechanical support from all the ligaments. All the ligaments surrounding the uterus. Okay. So all the ligaments like cardinal ligaments, which is major support of the uterus and the vault of vagina. It attach medial to superior supravaginal part of the cervix and vault of vagina, as well as laterally to the lateral pelvic wall. And uterosacral ligament responsible for keeping uterus in anteverted position. Anteverted tu dia ke depan into the bladder. Dia baring dekat bladder rather than dia baring dekat kita punya posteriorly. Is attached anteriorly to supravaginal party of the part of the cervix and vault of vagina, and posteriorly to the fascia in front of sacral vertebra. And pubocervical fascia is extension of the cardinal ligament, whereby this fascia attached to the supra part of the cervix, runs forward below the base of the bladder and split into two to allow passage of the urethra and attach the body of pubic bone. This is the diagrammatic that I'm talking about. This is the sacrum, inferior view, and this is inferior view. This is posterior part, which is sacrum here. Belakang ni ada rectum, at the middle have cervix, and then this is the urinary bladder. You can see the pubocervical, yang mana dia datang daripada supravaginal part and then it split into two to allow the urethra, and this is transcervical ligaments to hold the position, and uterocervical ligaments that keeping uterus in the anteverted position. This is lateral view. You can see how that all the ligaments wrap around the uterus and the part of the vagina to hold into its position. Okay. And then we have round ligament as also as a support, a secondary support of the uterus. We also have broad ligament, and then all the ligaments from the ovarian ligament, okay, is act of the support. This is the same diagram. Then we move into the support of vagina. For the support of vagina, it's very simple. You must remember what is the anterior and above support. Anterior and above support is by cardinal ligaments and uterosacral ligaments. That is anterior and above. Lower support from the levator ani muscle, which is levator ani muscle and the coccygeus. And hold into its position by urogenital diaphragm and perineal muscles, and posterior vaginal wall provide the anterior vaginal wall into the erect position, and perineal body and rectovaginal fascia is support the posterior part of the vaginal wall. But there is other classification that we can use or normally used by gynecologists. They use a support vagina ni, dia guna Delancey level system, whereby they have 3 levels how to support the vagina. First level is the uterosacral and cardinal ligaments. And I cakap it holds up anterior and above the vagina. Level 2, pelvic fascia and paracorpus, which connect the vagina to the white line and lateral pelvic wall. It holds the vagina into the erect position and hold into its place. And the third level tu biasanya is support the lower third of the vagina. Usually that is urogenital diaphragm and levator anal muscle. Dia support dekat bawah vagina. So this is other diagrammatic. Level 1, cardinal ligament, cardinal ligament and uterosacral. Level 2, our pelvic fascia such as vesicovaginal fascia, rectovaginal septum, they hold into its position and then hold it erect. The bawah tu support usually perineal body and then our urogenital diaphragm. So senang je, level 1, level 2, level 1 they hold atas, level 2 they hold tengah-tengah at the middle, and level 3 they hold the posterior part. So we're talking about prolapse. There are so many terms of prolapse. We have to able to identify which part is prolapse. First, it can be uterine prolapse, whereby there is uterus collapsing, falling down, and downward displacement of the uterus in relation to vagina. Nanti I show pictures. Second is vaginal prolapse. Portion of the vagina canal protruding from the opening of vagina. The vaginal wall itself going downwards, and it can be either prolapse ni, it can be either uterus alone, vagina alone, or it can be both. So there is so many grading system ataupun stages how to describe the pelvic organ prolapse. The most common one, there is 4 that I stated here. It has Porges classification, Baden-Walker classification, Granning, Babicam, and quantitative POPQ. Most of it show the same have the same effect to show the severity of the prolapse, but the landmark is very much different, whereby the Porges and the POPQ, they're using the introitus as landmark. Dia pakai sini. Our introitus tu. Tapi the Baden-Walker and Beckham ni, dia pakai hymenal ring. So the landmark is a bit different. So sometimes in the Beckham tu dia dah cakap first degree, tapi in POPQ is already stage 2. So it depends which classification you use. Don't jumble up. You guna POPQ ke, you guna grading system ke, ataupun you guna severity. Kan? So kena tahu which one you familiar with and most comfortable. But still we don't have any preference. Many urogynecologists still guna macam-macam, tak ada yang universal. So but nowadays we move to the POPQ, which is quantitative POP, yang mana is more quantitative rather than subjective. Okay, POPQ ni I explain briefly because I don't want to confuse you. It has a table consists of 9 parts, which is anterior wall, 2 parts of anterior wall, cervix, and 2 parts of posterior wall and fornix. And also they measure the genital hiatus, the genital opening, the length of perineal body and total vaginal length. So dia use measurement rather than kalau guna yang Beckham ataupun Baden-Walker tu, dia tak use measurement, they don't use the measurement, they only use the assessment by naked eye sahaja. So the staging from the POPQ system ni, dia ada stage 1 and stage 0 until stage 4. Stage 0 ni no progress at all. Remember, when you want to assess any pelvic organ prolapse, you must ask the patient to strain. Maksudnya kena teran. After you run for 6 seconds, baru you can can grade what is the appropriate severity for that patient. So stage 0, no prolapse is demonstrated during maximal straining. Stage 1, most distal portion to more than 1 centimeter above the level of hymen. Most kalau yang stage 4 ni dah complete the version of the vagina. I won't go into details because sometimes again it's very confusing yang orang yang tak pernah guna. Yeah? You just know there is a quantitative grading for pelvic organ prolapse, what we call POPQ. Okay. Anterior vaginal wall prolapse. Kan we talk about uterine prolapse, vaginal prolapse, or can be both. Kalau anterior wall vaginal prolapse, it can be cystosil or uretocil. Cystosil happen when there is descent upper 2/3 part of the anterior vaginal wall along with base of bladder. Maksudnya we can see in this picture, nampak you can see the bladder is downward displacement towards the vagina. Kalau it is a 2/3 upper. Kalau uretocil is descent lower 1/3 of the part of the vagina, yeah, the uteral displacement downward into the vagina. And it can be both cysto-uretrocil, prolapse of the entire vaginal wall, semua tu downward displacement. That is the anterior vaginal wall prolapse. Kalau you posterior vaginal prolapse pula, it can be enterocil. Enterocil ni prolapse of the upper 1/3. Upper 1/3 atas. Atas ni vagina cuff ni akan masuk into the vagina, posterior wall vagina due to close proximity of pouch of Douglas to the posterior fornix of the vagina. Maksudnya everything in the pouch of Douglas will be downward displacement into the vagina cuff, and it also descend along the prolapse of the upper vagina. In rectocil is prolapse of the lower 2/3 of the posterior vaginal wall in the lower part of the rectum. The rectum will have downward displacement. So, kalau anterior vaginal wall, you can have cystosil or uretocil. Kalau posterior vaginal wall, you can have enterocil or rectocil. Okay? So, this is ada diagram to differentiate. Atas ni is cystosil, you can see the bladder yang turun have downward displacement. Yang bawah ni, this is for anterior vaginal wall. Yang bawah ni is a rectocil, nampak rectum yang turun. Okay, the rectum turun, what we call rectocil. If the pouch of Douglas yang turun, you can call enterocil. And this is apical, maksudnya the uterus dia yang turun, center. So kita tahu tadi at the front we have bladder, at the back we have rectum, and the intestine, at the center we have uterus. So apical ataupun center ni adalah uterine prolapse. So what happened? Why we have uterovaginal prolapse or pelvic organ prolapse? In the normal situation, this is our reproductive system situated. It hangs by all the ligaments and supported by all the ligaments and muscle. But when there is excessive straining or stretching, you can see there is a stretch of the all ligaments, the uterosacral ligament elongated and stretched, also cardiac ligament, and also by all the muscle. This is occur when there is a childbirth, when patient more than 40 years old, when patient already menopause, obesity, and heavy exercise that can predispose to the pelvic organ prolapse. So what are the risk factors actually? First, obesity. Obesity affects directly to the pelvic organ prolapse. Because why? Chronic increase in intra-abdominal pressure, can cause nerve damage, and as well as comorbid of obese individual can contribute to pelvic floor dysfunction. They're going to have the neuropathy, they're going to have poor blood supply, so they tend to have pelvic floor dysfunction on top of the chronic increase of intra-abdominal pressure due to excessive strain of pelvic structure, including the pudendal nerve. So comorbidities such as diabetes contribute to poor tissue features through the neuropathy and genetic background and joint hypermobility. So when you have patient with pelvic organ prolapse, majority of them is obese. But non-obese patient also can have uterovaginal prolapse. Second is risk factor is genetic. Why? Women who have family history of prolapse, it has increased 2.5 folds incident of pelvic organ prolapse later, rather than patient who doesn't have any family history of prolapse in the family. Because why? The association seen between pelvic organ prolapse and other condition, there is an impact collagen quality, but we don't know and never investigated. And also happen in patient with any collagen problem like macam Ehlers-Danlos syndrome and Marfan syndrome, they have a high risk, high tendency to have pelvic organ prolapse because they have a collagen abnormality. Other than that, it's due to obstetric and gynecological causes. Multiparity have 8 times higher risk untuk dapat pelvic organ prolapse. Mode of delivery, instrumental is much higher than vaginal rather than cesarean section. But bear in mind, cesarean section does not prevent pelvic organ prolapse. Sometimes when you go to the Western countries, they don't want for vaginal birth because they don't want to strain their pelvic organ to avoid to have any pelvic organ prolapse later. No, that is wrong because pregnancy itself is a risk factor for pelvic organ prolapse. And also hysterectomy. Patient with hysterectomy is higher for uterovaginal prolapse because when you do hysterectomy, you ligate and you cut most of the vessels in the reproductive system. So the vessels in that area couldn't suffice the ligaments and the muscle properly, so the muscle become weakened and the ligament become weakened, so then they have much more high tendency to have pelvic organ prolapse. Menopause, hormonal changes in menopause also cause sudden drop in the systemic estrogen concentration. So the hypoestrogenic environment contributes to the pelvic organ alteration and composition and also of strength of collagen. So when you see in reproductive age, your skin is tightened, also as well as all your muscle and ligaments in your body. But after menopause, especially in women, you can see there is lack of collagen. Nampak dah all the wrinkles away. So you can see your variable wrinkles on your face and your skin, but also on your muscle and ligament also start to wrinkle already. So that's why menopause, one of the risk factors for pelvic organ prolapse. Other than that, acquired cause risk factors such as chronic constipation and chronic cough, and as well as abdominal masses. So when you taking, if any patient comes to you in primary healthcare complaint of pelvic organ prolapse, you must assess this their risk factor. Kalau tak ada, tanya whether they have chronic constipation or they have chronic cough, that patient have asthma, because when we want to treat this acquired risk factor, we have to eliminate first, then our treatment can become successful. Okay. So what is pathophysiology? If you see this picture, it is actually stage 4 ataupun kita consider presidential, all part of the whole cervix and the uterus as well as the vagina is already protruding out from the introitus. Yeah? So the pathology, in addition to descent of uterus and prolapse of the vaginal wall, following changes may occur macam elongation and hypertrophy of the cervix. Cervix will become elongated. Usually normal size cervix 3 to 4 cm. You can see here it can go up to 5 centimeter or 6 centimeter because slow progression of downward displacement. Second, it becomes keratinization of the vaginal epithelium. The normal vaginal epithelium you can see moist, pinkish, but In here, patient with uterovaginal prolapse, especially presidential, you can see there is a keratinization will occur. And patient will be predisposed to decubitus acceleration. Sometimes because of the gravity, the poor blood supply, they become decubitus acceleration. So when you inspect, especially when you inspect presidential, you must see 360 of the prolapse. Tengok dekat bawah dia, you can see any ulcer ke tak. And if ulcer, you can give antibiotic and treat accordingly. Incarceration of the prolapse happens when the prolapse become edematous. It cannot be reducible anymore, and then the blood supply being shut down, and patient will come with severe pain because it will be incarcerated. And sometimes patients come with urinary complications such as infection and urinary retention. Bear in mind, patient with pelvic organ prolapse, dia bukan datang dengan incontinence. Usually they come with urinary retention because of kinking of the urethra and bladder. So dia difficult to pass urine. So what are the common symptoms patient will come to you? First, most of the time, patient something coming out from vagina. Oh, doctor, there is something coming out from my vagina. They also can come from lower abdominal pain, but you don't suspect lah patient come with lower abdominal pain straight away pelvic organ prolapse. No, They also can come with backache, vaginal discharge, urinary symptom, constipation, and pain during coitus. Okay. The sign usually visible during inspection of vagina, depends on the degree. Sometimes kalau yang gambar yang the picture that I shown before, you can see that's no doubt there is uterovaginal prolapse. But if the prolapse is not severe like in first degree and second degree, you cannot see. Sometimes you can see stress incontinence during full bladder, and rectal examination is helped to differentiate rectocele and enterocele. What about the treatment? The treatment is always a prevention, physiotherapy, pessary, and surgical treatment. So we go to the prevention. So repeated childbirth, macam yang saya cakap tadi, multiparity 8 times higher in short, to have pelvic organ prolapse rather than nulliparity. So repeated childbirth in short-term intervals cause prolapse and advised to avoid pregnancy in quick cessation. Maksudnya you have to space your pregnancy carefully, at least 2 years. Within the 2 years, you have to do some sort of exercise to strengthen back your pelvic organ muscle, and also as well as ligament. And we can do during labor process, there are always prevention that we can help, which is in first stage of labor, we can avoid bearing down. Maksudnya, if the os not fully yet, don't ask patient not to bearing down. And bridge or forceps delivery before fully dilatation of cervix should be avoided. Macam patient already 8 cm, we ask you to tolerant, don't. That will predispose her to get pelvic organ prolapse later. In second stage, during the delivery of the fetus, during the crowning, avoid prolongation. Maksudnya, don't ask the patient to teran lama. After 30 minutes for multiparate or after 1 hour, you have to assist and perform episiotomy if overstretching of perineum nampak merening ataupun very stretched perineum, especially in nulliparous. So we have to help them by perform episiotomy. In third stage pun boleh. We can help to prevent pelvic organ prolapse, avoid Critz method. What is Critz methods? Critz method is actually contour cord traction. Contour cord traction, di mana when we deliver the placenta, we put our hands at the patient suprapelvic area to avoid the uterus, to avoid uterine inversion. But this method actually is predisposed to pelvic organ prolapse. Why? When we pull the placenta out, there is a stretching of the ligament and the pelvic muscle. So it can predispose to pelvic organ prolapse. And if after the third stage, the episiotomy or any test should be carefully sutured supaya the muscle strength will come back as normal. So postpartum, you have to treat constipation. Make sure patient will not constipated after during confinement period. There is no chronic cough, and provide strenuous exercise and prolonged standing. Physiotherapy also help for pelvic organ prolapse. Early onset of UV prolapse can help by pelvic floor exercise. Is effective during postpartum period or awaiting surgical intervention. And Kegel exercise used to tone up pelvic muscles and strengthen muscle power. So Kegel exercise we can do in female as well as male. Both can be benefit. So 4 facts known about Kegel exercise is commonly prescribed to improve many condition. If you have if you have pelvic organ prolapse, if you have any urinary disturbance, if you have dyspareunia, you can do Kegel exercise. So how to do is lift your pelvic floor and contract your muscle. They can be done at any location, home, office, or in the car, and have proven effective in reducing urinary incontinence also. So how to do Kegel exercise? Start by choosing a position, sama ada sit upright ataupun lie down with your knee bent and feet on the floor. Continue to breathe normally. Pull out and tighten the muscle around your vagina and anus so the muscle are squeezed up and in. So hold for 3 seconds and relax for 3 seconds. Repeat for 10 times. You can do 3 times a day. So every time you do, you can improve. Hold for another, let's say the first week you hold for 3 seconds, the second week you hold 4 seconds. So upgrade yourself until you reach 10 seconds. Okay. So benefit by doing Kegel exercise. So ease the menopause symptom, provide support to several organs, especially our reproductive system, facilitate normal vaginal delivery kalau you do in pregnant lady, prevent and control urinary incontinence, improve sex health, and in male is the prostate problem and restore erectile function also. So we move along to other treatment for uterovaginal prolapse is pessary treatment. Pessary treatment ni actually is a mechanical device for correcting and controlling UV prolapse. It does not cure. It cannot, if already you have prolapse, it cannot be undone. It's only hold the position so then it's not progress into worsen grading. It's temporary measure for women who refuse surgery or not fit for surgery. And there is 2 types of pessary, which is support filling and space filling pessary. In our center, in army services, we only have support pessary yang kita panggil ring pessary tu. That is support pessary. But there is other pessary that in the market or worldwide, as ring pessary that you will always use. Ring pessary, donut pessary, Hodge pessary ni semua is a space filling. It's just it's just a support you put at the level of the cervix to hold the uterus and the vagina into its position. Kalau patient yang dah postsidential ataupun much higher grade pelvic organ prolapse, kita boleh pakai gel horn pessary ataupun yang jenis space filling, dish pessary ataupun jeram. Dia lagi space occupied, lagi senang. Because sometimes kalau yang dah higher grade ni, when you use ring pessary ataupun support pessary ni, dia senang dislodge. So management of ring pessary, of the pessary, choice of pessary. Make sure usually this is done by the specialist lah ataupun urogynecologist. Which one is more suitable to the patient? I don't think the pessary, you have the pessary in the upper part. The size of the pessary tu varies between women, 60 mm ataupun sampai 100 mm. We have to measure properly and then see. There is no proper technique untuk determine what is the correct size. Sometimes we have to try and error. Yes, sterilization, make sure it be done in sterile and clean environment. Insertion of the pessary and follow up. Kalau kita when we put the patient in pessary, patient we have frequent follow up to change and wash and put inside the new pessary. Kalau when you look at this picture, you can see this is the uterus, vagina and bladder. This is where we insert the pessary. It holds the vagina and the uterus back into its position. So then it doesn't worsen the condition. Surgical treatment is always the best, is definitive treatments. It varies according to the severity and compartment involved. Sometimes it's only apical. You can do vaginal hysterectomy if any anterior wall vaginal prolapse, maksudnya is accompanied by the cystocele or uterocele. You may require colpoperineography, colporaphy ataupun involve the posterior part of the vagina macam dia ada enterocele or rectocele. It can be vaginal hysterectomy can accompany by perineography. Hysterectomy and colpoclysis is performed in postmenopausal women. Colpoclysis, this is when you stitch up the vagina without taking out anything. Maksudnya you put back all the prolapse organ back into the vagina and you stitch it up. There are only two opening or one opening yang akan be left open, which is the urethral opening, and then the other opening for the vaginal discharge to coming out. Maksudnya kita tak buang apa-apa pun. We only stay at the vagina, so then it doesn't keluar from the vagina. This colpoclysis usually we offer in patients who are not fit for long surgical intervention. Maksudnya patient have chronic diseases, tak boleh fit for long operation untuk buat ada hysterectomy ataupun perineal repair, so kita buat colpoclysis. Okay. So other than that, after you buat surgical treatment, you must treat the acquired lah. Maksudnya kalau patient ada chronic constipation, chronic cough, must treat that also. And then emphasize the patient physiotherapy. Although we already taken out all the prolapse organ, sometimes the void prolapse can also be happen if the acquired ataupun if the underlying risk factor not being corrected. So after operation such as hysterectomy, subsequent follow-up also important to avoid the void prolapse later happen to that patient. Okay, I think that's all my presentation. Thank you. Any question from the floor?
Thank you, ma'am. So far from the floor, I can't see any question. Ma'am, the question is from me, ma'am. Can I?
Boleh.
Okay, ma'am. Once this is usually a patient's view. Once they done the surgical intervention, they feel that the problem is settled. So subsequently, the care, post-op care is not really followed by patient. So in that case, once after the operation, is it still have chance for the vault prolapse? And what is the actions and what is the advice that we should give patient for that, ma'am?
Okay, good question, Sanggari. Like I said before, remember if you have any pelvic organ prolapse, there is a weakening of ligaments and the muscle. So by doing hysterectomy, you remove what is prolapse, but you not restore back the weakening of the muscle and ligament. So first, you must inform patient you still have 15% chance to have void prolapse later in 10 to 15 years after surgery management. Second, you must continue Kegel exercise ataupun physiotherapy throughout your lifetime. Sebabnya it's not only benefit for pelvic organ prolapse, it benefit to ease the menopause, it benefit to hold to improve your urinary symptoms. Okay, the third one is you must treat the underlying risk factor like I said, like macam kalau ada chronic cough, kalau ada chronic constipation, you must treat. So you must tell patient, Even though we already do a surgical intervention for them, it's not the end of story. You still have risk about 15% for void prolapse later. Not not bukannya pasti but still have risk. So you must explain properly because sometimes kan patient akan datang, oh dulu dah buang rahim, kenapa jadi balik? So you have, this is type of patient yang do not understand or the doctor doesn't counsel the patient properly. Okay?
Okay, ma'am. One more question from Dr. Aisha. Can ring pessary change at primary care level if the patient have her own ring pessary, already confirmed diagnosis by ONG team, maybe due to logistic issue and everything? Can that primary care doctors can do can change the ring pessary, ma'am?
Boleh, actually can. Some of the patient which are educated patient, kita bagi pun dia orang change sendiri. Because they dah lama on ring pessary, they know how to change, how to clean, how to wash and everything, they can change by themselves. Ataupun the doctor in primary health care, we train, they know what to do, how to change, how to take care of the problem, how to follow up. Then boleh, tak ada masalah. There is no there is no rule yang kata it might be changed by specialist. No, if you think you done enough, you can do with proper technique, then you can change for for patient, that particular patient.
Okay, ma'am. Thank you so much, ma'am.
All right, thank you.
I hope everyone enjoyed this topic today. We will be right back after a short break. Maybe we'll take about 5 minutes break. Then we will continue with our last topic for today's event. Thank you. Welcome back, everyone. We will continue our final topic for today's event by Colonel Dr. Shazni Izana binti Shahrudin, taking better care of the diabetic pregnant woman. Welcome, ma'am.
Thank you, Sangari, for inviting me again to speak for our last session today. I hope there's still some of us online listening. This is the end of our webinar. So please brace with me. I'll take you briefly through this topic. So the last topic shall be on taking better care of our pregnant diabetic mother. So let's just recap on the hyperglycemia condition in the pregnant population. So on a background, hyperglycemia is one of the most common medical conditions that women will encounter during pregnancy. And if you see this number, okay, from the IDF, it's not going away. So they've postulated that in 2019, it's 20 million, and across the board up to 2045, it'll just be around the same figure. So 20 million to 18 million is not too much of a difference. So it is still a staggering number. And let's see the prevalence across the age of these women. And we know, and is somewhat expected, that as the maternal age increase, you have more numbers of hyperglycemia. Okay, now bear in mind, okay, the other thing that we need to note, that as our nation climb up from a developing world to a developed world, many more women will consider halting childbearing to a later age. And as you see, once you hit 30 and above, the numbers somewhat goes up. Okay, so diabetic in pregnancy, there's two conditions. We have diabetic in pregnancy. These are the ones with pre-existing diabetes even before pregnancy. And the other one are the gestational diabetic mellitus. Now, diabetes in pregnancy are the one with previously known type 1 or type 2 DM, or hyperglycemia diagnosed for the first time during pregnancy that meets WHO criteria for DM in the non-pregnant state. And it can occur at any time during pregnancy, including the first trimester. Now, for GDM, the hyperglycemia during pregnancy, but it exists in a non-diabetic patient. Okay. All right, previously a non-diabetic patient, and the hyperglycemia diagnosed is noted first during that particular diagnosis, and usually occur mostly after 24 weeks. Now, the other thing I want us to see is this very big landmark paper, which somewhat, rather changed the whole scenario of how we manage our diabetic mother. This is a very important study. Our master student will know this is a frequent exam question. It's called the HAPO trial, the hyperglycemia adverse pregnancy outcome. Now, it was done over 25,000 pregnant women, over 15 centers and 9 countries, which includes Thailand, Hong Kong, and Singapore. Now, I mentioned this because you know this is a randomized multi-center across the board, and it has our population. It has Singapore, Hong Kong, and Thailand. So that would somehow, we know somehow rather that this study would somehow be true to our population. Okay, they measured the risk of adverse pregnancy outcome. In pregnancy with diabetes lah. So they see that birth weight of more than 90 centile, clinical neonatal hypoglycemia, the rate of the frequency of cesarean section, and as well as cord blood for serum C-peptide. All of this is high, and look at this. As the glucose level goes up, the increment in the frequency is exponential. It does not plateau. This is what is worrying. Hence the reason why in pregnancy, we bring down as much as possible, because we know the increment of all these adverse outcomes are an exponential. The higher the risk, the higher the blood sugar control, the poorer the blood sugar control, the higher the blood sugar is in a pregnant mother, the more the risk for the baby. And this is beyond a doubt proven by this HARPO trial. So risk factors are women, risk factors for diabetes in pregnancy are women with BMI more than 27. Okay, for Malaysian, for RCOG, they take about 30 kg per meter square. Now, previously, macrosomic baby weighing more than 4 kg, RCOG actually defined as more than 4.5 kg. Previously, women has gestation diabetic mellitus, or these women have a first degree relative with diabetes, or they have unexplained IUD, or history of congenital abnormality, or glycosuria at the first or any prenatal visit, or concurrent obstetric problem, especially essential hypertension, pregnancy-induced hypertension, or that pregnancy you notice that they have polyhydramnion. Okay. Now, how do we screen these women? So we have this modified or MGTT. We use the 2 hours using the 75 gram of glucose. Okay. So we would take a fasting sugar, and we would ask the women to drink this glucose concoction and repeat a test after 2 hours. So we offer this women this OGTT if the patient in previous pregnancy they have diabetes or GDM, or as soon as booking, or in the second trimester between 24 to 28, depending on the previous result. Okay, so if a woman have any of the risk factor, so they are in need to do this. And a single abnormal result is confirmatory, so you do not need to do twice. I've seen someone doing twice. The first, even if the first MGTT comes out as 5.1 and 7.6, and you're confused. Oh, it's so borderline, but the criteria fits that falls into diabetic. You do not need to repeat, just treat her accordingly. Okay, there's no benefit in differentiating between pre-existing type 2 DM and GDM in sense of management and treatment goal, because it is the same in pregnancy. Okay, the most important, so what this statement is trying to say is that as long as you have type 2 DM, as long as you have hyperglycemia in pregnancy, be it is a type 2 or GDM, the management and the treatment is the same. Of course, if you talk about long-term management for subsequent pregnancy implication for this patient in the long run, then certainly that matter. But as far as that particular pregnancy is concerned, once you diagnose a hyperglycemic state in that pregnant woman, then the management and treatment goal is the same. Okay, so this is the algorithm. I shall allow maybe a few seconds so that you can go through this. I will not read it out. Okay, it's self-explanatory. Okay, so if you do the OGTT, okay, so you would be deemed diabetic or hyperglycemic state if your fasting blood sugar is the same or more than 5.1 millimole per liter, and your 2-hour postprandial value is the same or more than 7.8 millimole per liter. Okay, so the magic number is 5.1, 7.8. If your patient's first OGTT result is as such, you do not need to repeat. Take it as it is. Treat her accordingly. Okay. So the complication, okay, it can be differentiated into maternal, fetal, and neonatal. Okay, so in maternal, you can have preeclampsia, pyelonephritis, increases of infection. You will have increase in amniotic fluid. If the baby is large or amniotic fluid is more than you are at risk of preterm labor, operative delivery, and monilial vaginitis, okay, for the mother. And if it's pre-gestational, okay, then it's a fertility, recurrent miscarriage, difficult sugar control, ketosis, hypoglycemic attack, diabetic vasculopathy, IUGR, all right? And for fetus, you can have microsomia. Please note that a hypoglycemic state in pregnancy also increases sudden risk of IUD. So this must really be kept in mind and be cautious of, right? For fetus can have shoulder dystocia upon delivery and congenital malformation. Now, usually for you to have for the fetus to develop congenital malformation, usually presents in women with pre-gestation diabetes, not common in gestational diabetes. The other, so because during organogenesis, their sugar would have been high in the first place. Okay, so for the neonates, once the babies are born, it doesn't stop there. Even though it's out from the mother's womb, so the baby is still at risk of hypoglycemia, hyaline membrane disease, hypomagnesemia, hyperbilirubinemia, hypocalcemia, hypertrophic cardiomyopathy, birth injuries, birth asphyxia, and late effect, okay, obesity in adult and type 2 diabetics in these fetuses who were born to a non-control or poor control pre-gestational or gestational diabetic, okay. So let's look into preconception care. So it's important that we need to provide information and good advice as well as support to aid and to suggest these ladies to aim for optimal weight. So if you are above 27 BMI, then we do advise on losing weight and taking folic acid of 5 milligram per day until 12 weeks at least. Reduces the risk of neurotube defect. And certainly a woman who wants to get pregnant and has pre-existing diabetes, to suggest them to need to reduce the HbA1c level to less than 10%, because beyond that the risk of congenital defect are much higher. And not just that, the risk of miscarriage is also higher, beyond 10% of HbA1c. And if they are on statin and ARB ACE inhibitor, they might need to rediscuss with doctors in swapping of medication. And if the women are not prepared yet and have not reached optimum level of preconception care, then it is highly advisable that they be on contraception. Okay. So while they are pregnant, we would aim that their HbA1c level be less than 6.1%. And we need to bring that down without the problem of hypoglycemia. So on one point, we want this, if they are pregnant, to have low HbA1c, but it is advised that we do it gradually and not to whack them, because they will have hypoglycemia, mainly because the body is used to high sugar levels. Okay, now women would be good to have renal and eye assessment before rapid optimization of blood sugar control as well. So we would need to teach them how to do self-monitoring, and we would need to optimize all of the other medication if they have other medical comorbids. Okay, so we need to explain women with diabetes in pregnancy about the implication, both the short and the long term, of the diagnosis for her and the baby, and that good blood glucose control throughout pregnancy will, without a doubt, okay, reduce the risk of fetal abnormalities, birth injuries, induction of labor, cesarean section, and unnecessary post-delivery neonatal complication and also death. Okay, and that treatment includes not only medicine, it also involves diets and exercise. Yeah, so we need to teach these ladies that they need to self-monitor and the proper way in blood sugar monitoring. Okay, so one, don't forget to advise women in change in diet and exercise at the time of the diagnosis. Okay, if they have at risk, then advise even prior to that if possible. And then advise these women that gestation diabetes means that they need to eat healthy during that pregnancy, and emphasis on food with a low glycemic index should replace those with high glycemic index. And preferably all women, these ladies would need to be seen by a dietitian so that they would have an additional support and advice on dietary needs. And we need to also advise these ladies on doing regular exercises to improve their blood sugar control. Who says pregnancy cannot exercise? That's a myth. You can do a lot during pregnancy, including some form of aerobic, including some form of weight training. So please encourage our pregnant women to go for their regular exercises to keep themselves fit. So this is the other thing that I want to talk on, the significance of glycemic variability. So why do we use this term glycemic variability, and what does it mean? So you have patient A and patient B, right? Both have an HbA1c of 7.8, but let us consider, are their glycemic variability the same? This is patient A, this is patient B. Now, what do you think about each of these patients' glycemic variability control? Which is better? Now, certainly, because the variation of patient A is maintained. Look at here, look at A. A maintains just a touch around 3.5 to 8, 10, okay, around here. As compared to patient B, although the patient B's HbA1c is 7.8, look at this. They have high highs and low lows, okay? Now, of course, two HbA1cs are not the same, okay? Patient B has tighter and better control despite having the same HbA1c, okay? This is what I mean, all right? So glucose variability and the risk of hypoglycemia would be there if our look at this. I'm gonna repeat this again. So essentially, we need to understand that we have glucose variability. If we push it down too fast, you risk of hypoglycemia. So the average, this is the average fasting blood glucose, let's just say around 7. Okay, then gangho kan, kita mau turun cepat kan, we bring it to 5. Look at the patient's high highs and low lows. Not good, isn't it? So we don't want this, neither we want the high above, okay? We want something like this, okay? So in an ideal setting, we would like to bring down in the target zone between 4 to 6. This is what we want. We should not, bring it too drastically, and to the point that our combination of medication somehow rather encourages the patient to have high highs and low lows, okay? So that's where the exercise comes in, the type of food comes in, and why we need to maintain our glucose variability, okay? So in antenatal care, nutrition is important. So medical nutrition therapy using carbohydrate control meal plans that promote adequate nutrition so that they can have proper weight gain and no more glycemia in the absence of ketosis, okay? So a lot of women think that, when we got pregnant, it's actually a free time for us to enjoy our food. It's not, yeah? So for women with a normal pre-pregnancy weight, we advise 35 kilocalories per kg of body weight. But if you are obese or you're overweight, it is a moderate caloric restriction. How you're going to count it is 25 kilocalories per kg body weight, okay? And this is important because we do not want to go too low, because we do not want to cause IUGR or low birth weight, and of course we do not want to induce ketosis. Ketosis is not good for fetal brain. Just be mindful on that. And also carbohydrate intake should be limited to about 45% of the total calorie. So I could say that it's not really a keto diet that if women are obese and have diabetic, but it's near there, okay? My bar bar that ensuring that the patient does not develop ketosis. So you want to have some form of caloric restriction, but ensure that it's not too low, too less amount of food, and it does not induce a ketosis. Okay. So if you notice in our buku merah tu, dah tulis dah sebenarnya sama ada patient baca ke tidak ataupun doktor pun baca ke tidak. So so please ask your patients to just go flip at the back of our red book. There's actually some suggestion of what to eat and what not to eat. Yeah, and also please let's remind our patient to exercise during pregnancy as well, and not to forget that. So this is the total weight gain and rate of weight gain during pregnancy. If you are underweight, the advised weight gain is between 12 to 18 kg. If your BMI is normal, then it's about 18 to 16. If you're overweight, which I think most of us are in this area, 25 and above, it's 7 to 11. And if you're obese, it's about 5. And usually I take the one, I usually like to take the one here because I think it's safer. So if a patient is underweight, you probably want to say, okay, maybe under 15, under 12. If you're normal weight, keep it under 10. If you're overweight, maybe under 7. If you're obese, keep it under 5. Okay. So unfortunately, in our setup, we see a lot of women allowing themselves to gain about 20 kilo, and even those who are underweight, they be going up to about 25 kilo, which is alarming. And you need to make sure that they are not diabetic. So for self-monitoring blood sugar control, should be done during the following time. It's spread out depending on what type of medication that you're on. So usually we do a fasting, which is after 8 hours from the previous meal. Okay, and then in Mizan or in most centers in KKM, we do 2 hour postprandial. We don't do 1 hour postprandial, and we would also do at times if the sugar is not too well controlled, especially those with insulin, we do a pre-bed glucose. Okay. So it's important to tell your patient that just because that is the day that we do your BSP, that must be the day that they take their normal diet, not the day that they take the least amount of calorie throughout the whole day, because it will be non-reflective of their actual day-to-day eating habits. Okay, so what is the second magic number? The first magic number is for OGTT is 5.1 and 7.8, right? And the second magic number is your 5.3 and your 6.7. I think just submit the 1 hour because we don't really use it. Just please use this one, okay? Not a good color, but doesn't matter. Okay, just please use this one. Okay, your fasting should be less than less or equal to 5.3, and your 2 hour postprandial should be equal or less than 6.7. Okay, so first magic number is 5.1, 7.8. Second magic number for BSP control is 5.3, 6.7. Okay. So if you have someone who clearly needs some help and we need to start on medication, so it is reassuring now that we know all these oral anti-diabetic agents are not contraindicated. Okay, you just need to know their pros and cons of each of the medication. And the metformin especially is something that we use widely now. It is not associated with any birth defects. And sometimes metformin can even be used in women with polycystic ovarian syndrome. And they see that if you use this in PCOS patients, you even see an earlier benefit, which is reduction in miscarriages and a fasting serum insulin level, which is better lah. Okay. Now, the risk of glibenclamide in GDM patient is associated with higher and increased risk of neonatal hypoglycemia, high maternal weight gain, and microsomia. Hence, we do not use glibenclamide exactly. But it is now proven that neither of the oral antihypoglycemic agent, the traditional ones, the metformin and gabapentin, might actually cause any fetal defects. But the newer ones, I don't think there's any study with that, and we do not use that. Okay, the one that we use more often now is metformin, just to increase the insulin sensitivity or as a prior treatment before we start any insulin. Okay, so HbA1cs are reduced by 1.5% by using metformin, and in combination with the insulin, it promotes a synergistic effect in the control of blood sugar. Okay, however, I think if the center that you are working on can give the slow release, that would be better, because a common side effect would be nausea and diarrhea. So if if you have the extended release, that would be a better idea to give this patient. And of course, when you start metformin, you want to tell them that you might feel some, nausea and diarrhea, but this is usually short lasting, and within a week or two, it will go away. Okay, so metformin is not for long term because it is associated with B12 deficiency. But I think a lot of us, if you've managed enough numbers of patients on metformin, or you yourself have taken metformin before, for whatever reason, you will notice that you have less of an appetite when you're on metformin. So in a way, it does somehow rather controls your weight and causes less weight gain. So low dose metformin is also safe for lactating mothers. So this is the combination that I mentioned. So formulary minimum dose. I think for pregnancy, it's best that we give more than 850 per day. Per day. Minimum is 850 per day. So if you have the SR or the XR, this is preferred over the short-acting metformin. But if you don't have, then it's fine. You can start 500 mg BD or 1 gram OD, depending on how you want to use it. So maximum dosage for your metformin biasa is 1000 mg 1 gram TDS, metformin SR 850 mg TDS, and the metformin XR is 2 gram OD. Okay, so now you see a needle kind, so you know next one I will be talking about insulin. Okay, so if your target is not met by usage of after food control and then using all your OHA, you give it about a week or two, it's not met. So please consider insulin fast. I've seen patients being put on metformin over 1 month and the target's not met, and then by the time sampai kat kita orang dah dekat 2 bulan. So I think that's a bit ill timing. Please aim. If the target's not met, maybe in the first 3-4 weeks while patients not adjust to please terus refer, because we clearly know now that they would actually need some insulin to help. Okay. So insulin in pregnancy, this is how we usually calculate. If it's in the first trimester, it's 0.7 unit per kg per day. Second trimester is 0.8 unit per kg per day, and the third trimester is 0.9 unit per kg per day. All right, and then we titrate accordingly. Now, how to choose? Most importantly, it depends on what is available at your setting. Okay, but of course, we are moving towards the long-acting analog, especially for those very high resistance. Okay, we've seen that even we give the insulatide, sugar is very high. So sometimes we consider using your longer acting like Levemir, which is a D-dimer, because there's a least peak action. And look at this, the duration of action. Okay, if you have the atropine, normal atropine is 6 to 10 hours, hence why it is a short acting. Okay, we do not use your Novorapid duration of action is 3 to 5. So Novorapid, that's why if kita nak address just the premier tengah hari tu, this would be good, 5 to 10 minutes before meal. all right? But look at this, the longer acting. This is for the basal control lah, basically. Insulatard has 8 to 12 hours duration of action, but the long acting ones macam Levemir is 16 to 24. But be mindful, Levemir only specialist yang akan decide untuk bagi, and usually that is after we have discussed with our medical colleagues sometimes, if those are very resistant. So be mindful of this duration of action because the timing of the administration matters. If you are giving Actrapid, so it's 30 minutes before meals. If you're using Novorapid, it's 5 to 15 minutes before meals. And Insulatard and the long-acting are about the same. So pre-bed lah. Usually it's pre-bed daily. So what's the aim? The aim the aim is to reduce glycemic variability, and you want them to achieve a sugar tone control within their target zone, okay, without hypoglycemia and hyper. So we try to maintain within the target zone 4 to 6 with no low lows, with no high highs, okay. So this is something I think yesterday's presenter has talked on preeclampsia prophylaxis. Why is it also an issue in diabetic, and why it is mentioned in diabetic management? Because a woman who has diabetic in pregnancy are at risk of developing pregnancy-induced hypertension, and anyone with pregnancy-induced hypertension has the risk of preeclampsia. So if you have a woman before the age of, who you diagnose with diabetes in the pregnancy, please start them low-dose aspirin between 75 to 150 milligram a day before the week of 16 weeks of gestation. And the Cochrane system review also report that high dose of calcium supplement, more than 1 gram per day, also reduces the risk of preeclampsia. There's also a study on vitamin C and E supplementation. However, they see that it doesn't really prevent, so they've dropped that advice in giving to women with as a preeclampsia prophylaxis. Okay. So this is the timetable for antenatal appointment. Okay. I actually took this from one of the CPG. So just go through, okay, nothing out of the ordinary. So essentially, when you do your first RME, remember my first topic was on the RME. Someone asked about RME, right? So when the RME, make sure you risk stratify your patients, and make sure that we do not miss to do an MGDT early if it's necessary for her. Okay. All right. So if the woman has no risk at all, so the first OGTT, kalau paling lambat pun you boleh buat at 24 weeks, okay, and you might want to consider plus minus repeating at 38 weeks. I know now OGTT is done the moment after RME around 16 weeks lah, just so that we don't miss any diabetic mother. But if you have, if they requested to postpone and they have no risk at all, and you want to, and they say, can I just, or you have a patient who keep on vomiting up with your Trutol too, so you might want to do around 24 to 28 weeks, all right? But if a woman is highly have many risks, then you do one in the first trimester. If it's normal, you do one at about 24. If it's normal, you might want to consider repeating between 28 to 32 weeks, just so that we don't miss any diabetic in pregnancy for that woman. Okay. So timing of delivery would be depending on how their glycemic control is and if they are on medication. Usually patient with good control and only on diabetic diet, then we may allow them to go to up to 40 weeks, but we do not practice delivering post date. Okay, but if they are on medication, it's 38 weeks. All right. Now, if they are on medication and very poor control, we consider once they hit 37, once they hit term, or sometimes very poor control, very with polyhydramnion and very big babies, we sometimes even bail out at 36, case to case basis. All right. Now, something to consider, continuous glucose monitoring is the way for diabetic management now. It's not well taken out yet by I think the obstetric community, mainly because it's expensive, and I think you have to have a lot of self-will and self-control to do continuous glucose monitoring. But I think CGM is something you can implement with women who have very good social support and very good mental health. They read and very educated, and if they really want to control the sugar well, something to consider. Okay. Now, the other thing in managing diabetic women, I find very crucial, is that you must make sure that they have good mental health. Because in my experience treating diabetic women, the hardest to treat is the one who has unmet mental health issues, and it has not been optimized. Those are the hardest ones. So be it mental health doesn't mean that you have depression, anxiety alone. Sometimes just behavioral can be your eating habit. You're not ready. This is a unwanted, unplanned pregnancy. It will affect how these women perceive their pregnancy care. Okay. So I've mentioned this just now. I will not mention again. So in labor, we would maintain blood sugar control of 4 to 7. And if it's not well controlled, very high in labor, then sometimes we give insulin infusion. Jaranglah perlu sebenarnya. Okay, sebab in the first place, pregnant women with insulin ni wouldn't have too high of a blood sugar pun, because if they are very high, they will not proceed with the pregnancy. Okay, so this is the intrapartum algorithm. Okay, this is in our guidance, our CPG. Nothing new. Okay. And this is the insulin infusion algorithm for titration in active labor. Okay, so postpartum, important to note that the insulin requirement drops by 60 to 75% in women who have gestational diabetes. And then when breastfeeding, if glycemic control is inadequate and diet therapy alone, sometimes you can consider insulin, but at a lower dose. And most women diagnosed with GDM should be able to discontinue the insulin immediately after delivery. Sometimes you don't have to give insulin anymore, just give them on metformin, they'll be okay. All right, but it's important to know which one you want to give, half a insulin with or without metformin, depending on the mode of delivery. If they go for cesarean, you know that you have to have good control for the wound optimization. So you might want to consider a low dose insulin on top of your metformin for the next maybe few weeks. For as a management lah. Tapi usually this one resap bapak tak payah risau sangat. Kita orang yang kat hospital ni akan bother. Most importantly, because sometimes some of your centers does home visit, you just make sure that your nurses are mindful of this. Okay. Those whose blood sugar normalizes immediately after birth, after delivery, these are the ones with very good control. Usually, make sure that you do not forget to do a 6 weeks postpartum and GTT. All right. And all women who has GDM, they need to be advised that future risk is there. Okay, so they need to make sure that before the next pregnancy, they bring down their BMI, they be healthy, they make sure that they have that exercise going on already. Okay, as a conclusion, okay. Oh, sorry. In pregnancy with diabetes, whether or not they are pre-existing diabetes or gestational diabetes, HbA1c should be aimed to be less than 6.5 as a target for those with history, and universal screening to be performed between 24 to 28 weeks using MGTT. And women who have high risk should be screened at booking, and if the result is normal, to repeat back in 4 to 6 weeks time. And if a woman who doesn't go well with their sugar monitoring, with diet control, or even their metformin, their OHAs, then the insulin should be started. So BSP must be 5.3 6.7. Remember that, tak payah ingat 7.8 tu, unless you memang nak tengok 1 hour lah. Kalau for many of us, we just do fasting and 2 hour postprandial. 5.3, 6.7. Okay. And then 6 week postpartum, don't forget to repeat the MGTT. And women who have GDM, be aware that they have a higher risk of developing diabetic in future years. So they need to be advised for diabetes screening. And the other thing is, don't forget mental health organization, because this is also important in making sure that our women are being taken care of well. All right, that's all, Dr. Sangari. I pass it over to you. Any questions?
Thank you, ma'am. I have few questions, ma'am, here. The first one, during MGTT, if the patient vomit, do we need to repeat the MGTT?
You do, especially if they vomit right after. So that 75 glucose it wouldn't be ingested and processed, so you might have a false negative.
Okay, ma'am. The second question from Dr. Aisha, calcium initiation for type 2 DM, and we also initiate PE. It's a PE prophylaxis, right, ma'am? In some center, we start the calcium, especially calcium carbonate, during when we do the booking and we confirm the viability of the fetus. But some starts 20 week. So Dr. Aisha wants to know which is the best time to start the calcium. Is it during when we start the aspirin, or we wait until 20 weeks?
Macam ni lah with calcium. Calcium ni besar gabak tau. Any one of us who's been pregnant know it's not easy to ingest that calcium. It's very big. So use your discretion. Okay, if the mother doesn't have very bad morning sickness, you can actually start early. If the mother have very bad morning sickness, probably delaying will be better, but try to aim somewhere around 16 weeks rather than 20 weeks. Calcium punya evidence is not as strong as aspirin. That's why we are not too anal about the calcium, but we do advise to give for those who can lah. But the aspirin must be started before 16 weeks to ensure that whatever mechanism in prevention of preeclampsia too is being disrupted at an early point. So as far as calcium is concerned, for me, whenever you see your patient canned, and if they don't like our preparation, they prefer the ones outside, so you can encourage them to buy their own if they want and they can afford to lah. Yeah. So I think for you see your patient to patient. But if you want to assist all your other MOs for the FMS out there, I would reckon the age where most early morning symptoms cease would be around 12 weeks and above. So maybe you can start beyond 12 weeks, perhaps not too late either.
Okay, ma'am. Another question, ma'am. Currently, our first line for GDM is actually to start OHA and especially that metformin. Can our medical officers in primary care, can they start the metformin, then they refer to ONG team to monitor the BSP, or they still need to refer to us?
Then you can start. Why not? You can start, providing you know how to handle them. And the most important thing is like this. You don't wait too long. I've seen people starting and they wait until sebulan dua. Okay, you start, you bring them back in 2 weeks time, and you want to give them some time, maybe another additional 1 more week. But beyond the 4th week too, if it's not beyond the 3rd, 4th week, if it's not addressed, you need to refer to the ONG's team lah. Bear in mind, all these sugar optimization is important, because at any point of high sugar, it can cause IUD. IUD is a M&M, right? It goes to national mortality. You're gonna have to answer if you don't do that. So I say don't wait too long. You can start first and refer. If you want to start managing, you can talk to your FMS. I know all your research have your own FMS under each division. You can talk to your FMS and decide. So don't wait too long. You want to give, boleh. Bring 1 more week. Tapi kalau tak sugar tak control, refer teruslah, senang.
Okay, ma'am. The final question is, who we should refer for detailed scan? What is the HbA1c level? mean, the alarming level that we advise mother to do the detailed scan, and when is the ideal gestation to do detailed scan, ma'am?
This question is a bit technical. Usually, anyone whose HbA1c is more than 9 needs to refer. More than 8 needs to refer. However, you need to find out the MFM nearest to your center, because I'm sure the one listening today is not just from around Klang Valley. It will be from other states as well. So you need to find out. If you don't have macam mizan, kita orang akan refer ke if their HbA1c is high, we will refer to HKL. So you need to find out what is the cutoff criteria that the MFM of your nearest referral hospital sets. In that sense, and if they do not, if it's you think it's necessary, meaning they have two components, macam advanced maternal age, and then the other component will be HbA1c of 9, tapi your MFM dekat that center nearest to you does detail scan only 10 and beyond, so maybe you can get another ONG specialist at the nearest to your center to do a detail scan. Sometimes they do that. Mizan, we do that. Okay.
Okay, ma'am. Thank you so much for the final topic, ma'am. I hope
everybody still. I hope everybody's. I hope there's still a crowd listening. So thank you for those who stayed on to the last. Don't forget to sign your CPD points and your feedback mechanism for your feedback registration, right? Feedback form, yes, to get your e-cert. I menyebut dah Sanggari sebab I coordinate the program kan, yes.
Thank you, ma'am.
Thank you. All right. Have a good weekend, everybody. Thank you.
Ladies and gentlemen, finally, we come to the end part of our webinar today. We would like to thank all our presenters and all the audience for your anticipation. We hope this webinar will be beneficial for you, especially to our doctors who is in primary care. Kindly don't forget to scan your MMA QR code and your feedback QR code before you leave the webinar. You have to scan your QR code, your MMA QR code for your 12 CPD points and your feedback QR code to get your e-certificate. So once you complete your feedback QR form, then the e-certificate will be emailed to your email ID which you use to register for this webinar. Thank you everyone and have a nice weekend.